Hey, hey, hello. Check, check. Hey, hey. Check. Hey, hey. Check one. Hey, hey. Hey, hey. Hello. Hello, hello. Check, check. Check, check. Hey, hey. Hey, hey. Mic testing. Check one. Hey, hey, hey. Hello. Hello. Check, check. Hey, hey. Hey, hey. Hello. Check. Hey, hey. Hey, hey. Check one. Check, check. Hey. Check, check one. Hey, 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 hey. Hey, hey. cheek, hee hee. Cheek. Cheek, cheek one, hee. Cheek, cheek. Cheek one, hee.
You like to play your own game. Cover it up, don't let them know what you're thinking. I bet you never tell them how it feels, how it feels. Cover it up, you like to play your own game. Cover it up, don't let them know what you're thinking. I bet you never tell them how it feels, how it feels. Cover it up, you like to play your own game. Cover it up, don't let them know what you're thinking. I bet you never tell them how it feels, how it feels. You have to play your own game. Cover it up, don't let them know what you're thinking. I bet you never tell them how it feels, how it feels. You have to play your own game. Cover it up, don't let them know what you're thinking. I bet you never tell them how it feels, how it feels. just an arm in a love. Baby, we just losing control. Now we're all feeling like lost. Need some more, I need some more. I need it again. I need it again. Need it. You like to play your own game. Cover it up, don't let them know what you're thinking. I bet you never tell them how it feels, how it feels. Cover it up, you like to play your own game. Cover it up, don't let them know what you're thinking. I bet you never tell them how it feels, how it feels. Cover it up, you like to play your own game. Cover it up, don't let them know what you're thinking. I bet you never tell them how it feels, how it feels. Your own game. Cover it up, don't let them know what you're thinking. I bet you never tell them how it feels, how it feels. Cover it up, you like to play your own game. Cover it up, don't let them know what you're thinking. I bet you never tell them how it feels, how it feels. वक्रतुण्डमहाकाय सूर्यकोटिः समप्रभा
वक्रतुण्ड महाकाय सूर्यकोटिः समप्रभा
निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
वक्रतुण्ड महाकाय सूर्यकोटिः समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
Welcome to the final day of DRS and WCPD conference. We are grateful for your presence and contribution. Let's continue to inspire and learn from each other as we strive for excellence in diabetes research and care. Thank you, and let's make the most of the last sessions together. I would like to welcome our chairperson, Dr. Vishal Vaidya, and Dr. Shruti Gangwani on the dais.
So very good morning, all of you. Another fine Sunday morning. To start off this session, we have the opening batsman in the form of an absolute legendary speaker, and I would request Dr. Shruti to introduce the speaker for today's first session.
Good morning, everyone. Starting the day afresh, I would like to welcome our first chairperson for today's session, Dr. L. Srinivasa Murthy. He is a senior consultant physician and diabetologist, principal investigator, medical director, Life Care Hospital, Bengaluru, Vice President, National RSSDI, Vice Chairman, Karnataka API, Executive Committee Member, National API, Executive Committee Member, CCDSI, Organizing Secretary of ACP India National Conference 2021 and 2022. Over to you, sir.
Thank you for the kind introduction. I think happy Sunday morning to everybody. We're going to talk about the triple combination of metformin, DAPA, and LINA. We're going to talk about the sustaining glycemic and non-glycemic pleiotropic benefits of this combination, and what are the burden of this, and what are the advantages of a FDC in our routine clinical practice. And these are my disclosures to begin with. And we know the diabetic patients in our country reaching the therapeutic goal of 7 and below, which most of us tend to aim in our routine clinical practice, only 70% do not achieve this target. That is the disheartening one, to show that the treatment with most of our diabetic patients is as only about 20 to 30% of them achieve the goal, and the onus is completely on us as a treating physicians. And this is what is another data to show that the time until intervention, which if you divide into 7.5 to 8 and beyond 8, you can see the 38, 31 and 28% is the respective control to achieve this. That means literally about 70-80% of the patients do not achieve the A1C goal of 7 and below. Now, what are the results for delaying in this A1C control is, of course, micro and macrovascular complications, and I'm sure everybody are aware about this micro and macrovascular. And of course, eventually the poor A1C control in the first year, if you do that, you are increasing the CV risk in the long term. So the legacy effect, what we all contemplate, and the cardiovascular disease, 8 out of 10 diabetics would end up eventually with CVD. 2 to 4-fold increase in the cardiovascular mortality and stroke is seen, and of course the neuropathy, which is most commonest. And the second commonest is a nephropathy or a CKD, which many of us neglect again in our routine clinical practice to pick up this CKD in the early life of their diabetic journey. So we need obviously the 360-degree approach to address this omnious state. I'm sure all of us are aware about this at literally every level. So the therapeutic approach should be maximum targeting the 8 or 9, the pathophysiological defects, and that is where we need to look at the early combination of the drugs so that we cater all the defects in this basic pathophysiological defect of diabetes. So these are the drugs which are contemplated or proven efficacy when you see at the level of the beta cell, at the level of the alpha cells. Now the GLP-1s and also GIPs are coming into picture, and increasing hepatic glucose output, that is TZDs, metformin, insulin, and of course GLP-1s. And at the level of the brain, the GLP-1 and also the GIPs have got now the combinations. Increased lipolysis is again metformin and insulin. That's one of the reasons. Prevents lipolysis, the insulin, and gives you weight gain, and metformin will be a good drug to negate that effect. And of course, reabsorption at the level of the kidneys, the only SGLT2s so far. So this is all the contemplated drug therapies. Now, when do you introduce these drug therapies is the question, because we know that about 30% of the diabetics need the triple drug therapy, and there is a significant percentage of patients who require this to control in our routine clinical practice, and we have this inertia of up-titrating very slowly. There have been enough evidence to show that maintaining glycemic targets with monotherapy can be difficult for a period of time, as you can see 3, 6, and 9 years when they are in metformin alone. And similarly with the sulfonylurea, as you can see the drastic fall of the control of A1C over a period of time. And what are the consequences of this delayed intervention? So this is what happens with 5.3 years, significantly increased risk of MI by 67%, stroke by 51%, heart failure by 64%. This is what you will end up if somebody who don't intensify the treatment when first 1 year when the A1C is above 7. So if you delay just by 1 year, that right side you can see at the end of 5.3 years, that is the amount of complications you will induce to the patients. So it's like you can call it as a iatrogenic effect because of our clinical inertia to up-titrate the drugs. And what are the benefits of controlling this? Way back, Advance has clearly shown us, UKPDS has clearly shown us that with just 1% reduction, the mortality morbidity benefits. I'm sure all of you are aware about these slides, but this is what we get. The glycemic control is definitely the key to reduce the burden of complications to the patients. And the UKPDS has got now 30 years legacy effect. As you can see, the effect of the good legacy period continues even after 30 years. That's something which is very, very convincing for us to know that. And so in diabetic patients, improved glycemic control in the initial stages will eventually reduce the complications. Now, a key strategy to reduce micro and macrovascular complications, obviously, this is something very important, very schematically shown here. Individuals with diabetes, early glucose lowering therapy, regular assessment, treatment intensification to achieve maintained goal, and this, the middle one, slide. Okay, this area clearly shows about how early you should intensify, which is, okay, this is also not working. Okay, now we need to incorporate the drugs at the earliest, especially the SGLT2s, GLP-1s over and above your metformin or the background therapy, and your goal should be to reduce the micro and macrovascular complications. So it's very, very important that we need to achieve the affordable therapy to our patients at the earliest during the course of the disease. So we definitely need combination agents that act on multiple pathophysiological defects, which we saw in that omnious actate slide. Now, what are the benefits of the combination therapy? Definitely, it addresses the various pathophysiological defects in diabetes, and there are multiple benefits of the FDCs like complementary action, benefit efficacy than monotherapy, better efficacy, enhanced glycemic control, and eventually, because of FDCs, the compliance and the adherence rate will improve. So why do we should consider in routine clinical practice the early FDCs? It should be considered in the patients where the A1C level is above 1.5 to 2% above their individual target. This is various evidences are there, various guidelines are talked about. High glycemic efficacy for CV and renal risk reduction, that SGLT2 should be initiated at the earliest. All of may allow for waning of the current regimen, particularly of agent that may increase the risk of hypoglycemia that you need to look at whenever you are trying to do these FDCs combinations. Treatment intensification may not necessarily follow a pure sequential addition, which is the classical approach which most of us are doing, and instead reflect a tailoring of the regimen in alignment with the patient-centered treatment goals. So if the A1C is above 7.5%, in general, early combination with the two agents may be needed. And for those who have the initial A1C beyond 9% or above 1.5% the goal, then 2 or 3 anti-hyperglycemic agents should be initiated concomitantly. Now, the triple drug combination and its role in our routine real world life is a combination approach is to address multiple pathophysiological mechanisms. It provides both glycemic and extra pleiotropic benefits. It reduces the risk of CRM, that is the cardiorenal metabolic common soil hypothesis, what we contemplate, reduce the occurrence of hypoglycemia and weight gain, and improves the compliance and reduces the pill burden. That is again a big deal in our routine clinical practice because most of the patients have the comorbidities of other diseases, and the pill burden is a biggest problem we face whenever we prescribe new medications. So the ADA 2024, if you see, I think the right hand top one, can anybody tell what is that written in that round with an arrow, which is in a very small letter, unfortunately, and that talks about our inertia. That says to avoid therapeutic inertia, you need to reassess, and the treatment regularly you need to update. That is what is written on that round small area on the right hand top superolaterally, I would say. That is what it is written, and most of us do not do that. Unfortunately, that is written in a small letters. That is what most of us should do, that you reassess regularly, up titrate the dosage, come out of the clinical inertia. That's the meaning of that. Now, if you see here in the right hand side, the glycemic management, the choose approaches that provide the efficacy to achieve goals. Metformin are agents including combination therapy that provide efficacy and to achieve maintained treatment goals, where the SUs and SGLT2s and of course DPP4s do reflect. And when there is a ASCVD, now we know that the SGLT2s with CVD benefits are SGLT2 with proven heart failure benefits. When it comes to the CKD, again, SGLT2 with a primary evidence of having the reducing the CKD progression are the drugs classes which we should include in our armamentarium whenever we tackle. And this is one of our own RSSD wheel, and the person who invented this is also sitting. I'm privileged to have Rajiv Savla sir here. He is one of the authors of the wheel, and the wheel is still going, running very fast, including in the international guidelines are adopted now. Again, we talk about the first line therapy and the combination therapy very clearly in this RSSDA wheel. Connecting mechanisms into clinical evidence. Now, when we talked about what is the necessity, now let us look at is there any evidence for the metformin dapalina combination, about their efficacy, all that. This is a 18-week multicentral randomized double-blind active control parallel group phase 3 study involving about 200 odd patients. This is basically for the DCGA approvals what we do. Group A, Group B, you can see the baseline characteristics are well matched, and the male female BMI A1C is about 9 plus, and the FBS PPBs you can see there. And what are the results? Clearly, the combination therapy have shown the efficacy with respect to the PPG, the FBS at the end of 16 weeks. That's the best part. You see at the end of 3 months, these are the values we get, and which are all statistically significant numbers when it comes to the tolerability or the body weight reduction or the FBS PPBS. That is the efficacy you have in the group A, which is there in the blue color dark. So the combination therapy end of the day resulted the clinically significant improvements in the glycemic control with a greater tolerability and safety. Now there is another study, phase 3, FDC dapalina over linagliptin monotherapy. This is another comparison which has been seen, test group and the reference group, and the primary outcome and the secondary outcomes are A1C and FPS PPBS body weight respectively. And you can see the baseline characteristics have been well matched. This is the primary outcome. The reduction of A1C is minus 1.3 with the dapalina metformin combination, and that's something which is there. And this is the secondary outcomes in the form of reduction in the FBS, PPBS, and the body weight. So incorporating dapa and lina with metformin provides clinically significant changes in patients with diabetes, as evidenced by the parameters of A1C and of course the body weight. So these are all the significant numbers. So adding SGLT2 DPP4 to metformin can result in early and durable glycemic goal. That's the gist of this triple combination. And of course, the series safety of metformin, dapa, and lina have been proven. UKPDS have clearly shown about the metformin, the UKPDS substudy 91. And the dapa CVOT trials, we know the declaratory heart failure, the deliver study, all these are clearly shown. So adding lina to dapa and metformin gives additional cardioprotection with robust glycemic control. And there is a synergism which has been shown with this combination drugs as well. And of course, the linagliptin, the Carmelina and Carolina, only DPP4 with both the CVOT trials, and clearly showed that there is a comparable or a better efficacy with the placebo and the glimepiride, which was the other arm. So the meta-analysis of this combination again gives us a lower risk of GTI compared to SGLT2s alone. That's another one which you negate, the so-called the calmness side effects, what most of us are worried, because there is the DPP4 enzyme in some of these bacteria and fungi, and this inhibitor also inhibits the enzyme, and thus the UTI, the GTA is a compound. So this is another better safety outcome evidence to show that the comparison of SGLT2 when you initiate versus you add SGLT2 to DPP4, it is a better one if you start with the combination to bring down the GTAs and the UTAs. And of course, the DPP4 inhibitors, you can see the sabertime, ticos, and the camelina. The camelina is the only one which has got the renal outcomes and the 3-point MACE advantages, vis-a-vis the sabertime, which triggered the heart failure signals, and the ticos are the CV neutral. Of course, so will the gliptin and teneligliptin no CVOT so far. So the holistic approach for diabetes patients with CKD, we can continue this triple combination until the eGFR of 30. This is the KDIGO guidelines, which talks about the metformin, SGLT2, RAS blockade, statins as the first line. And then additionally, we can use the GLP-1s, antiplatelets, and of course now the MRA, non-steroidal MRA is being used. And SGLT2 inhibitors with evidence of reducing disease progression is preferred. And that is what clearly mentioned in various guidelines, that it is going to be the DAPA. So is it a DAPA a suitable choice to add on to metformin in the background of CKD? That's what is something we need to look at. And this is the evidence we have with the DAPA CKD, declitimi, DAPA heart failure, which reduces the progression of heart failure and kidney disease in diabetic patients with reduced eGFR, and is important to improve the quality of life, CV and renal outcomes. That's been clearly shown in all these major trials with a huge number of combinations. So combining the LINA-DAPA with metformin diabetic patients, we can extend the cardiorenal safety along with the glycemic efficacy, and that's the crux of this talk. And additionally, linagliptin, we know that do not require any monitoring of UACR, and no dose adjustment is required across the segments of the eGFR. Just to show, a lot of evidences are there with this triple combinations as well. In the bottom, the gray area, which has been RCTs, and the systemic review is pink shaded, and the review is one which is there, our observational study on the first one. So the triple combination, there are enough RCTs to show that they are beneficial when you start early in the course of the disease, and that is something we should remember. Again, the long-term safety of Carmelina study, which I think we should again emphasize and look at when we initiate this choice in the triple drug. And of course, the reassuring long-term kidney safety profile is there with the linagliptin alone, not with any other DPP4s. So the early intensive therapeutic control of the FDC of the SGLT2 DPP4 metformin gives us the betterment of glycemia, reduces the adiposity, reduction of metabolic and vascular risk, simplicity for sustainable compliance and safety is definitely there. And so by this early combination, we can ensure early and better glycemic control, which can be durable with low risk of hypoglycemia and no weight gain, and improves the patient's adherence to treatment, and possibly reduces the clinical inertia, where we have that inertia to uptitrate in a timely manner, and it can offer more opportunities to address individual patient needs. To summarize, diabetes is a multifactorial disease with the cardiorenal complications, and appropriate OADs that act on the multiple pathophysiological defects should be considered whenever you initiate the drug therapy. The FDC of metformin, DAPA, LINA can address this issue in diabetic patients, and this once daily regimen eventually improves the compliance and quality of life, targeting the pathophysiological omnis octave of hyperglycemia. And the metformin LINA DAPA combination will remain an effective strategy for managing diabetics in the mind patient profiles, glycemic parameters, and cardiorenal risk factors. So a delayed intensification can significantly increase the risk of MI stroke in these already high risk diabetic patients. Studies have clearly shown that the early intensive glycemic control reduces the risk of both micro and macrovascular complications. Guidelines clearly recommend the combination therapy if somebody's A1C is beyond 1.5% above the target. Combination therapy acts not only on the multiple pathophysiological defects, but also provides a A1C reduction, which helps to achieve goals without increasing the pill burden to our subjects. Thank you very much for the patient here.
Questions? One or two short questions. If anyone has a query, we can take it. I think the lecture was self-explanatory, so the queries have been auto-resolved. Thank you so much, Srinivas Murthy sir. And the next session, it is an absolute honor for me to introduce the speaker of the next session, Dr. Rajiv Chawla sir. He's a senior diabetologist and director at North Delhi Diabetes Center, New Delhi. He's the past president of RSSDI, past president of DIPSI. He is the editor-in-chief of IGDDC, RSSDI textbook, and annual casebook. He has authored over 10 books on diabetes, a long list, but I think we can start because everyone knows the legendary speaker, Dr. Rajiv Chawla, sir. Please go ahead, sir.
Good morning. Thanks a lot for those kind words. At the outset, I am thankful to Team DRS and WCPD, precisely Dr. Purvi, Dr. Manoj for this opportunity. Task assigned to me is to discuss about preventing hospitalization with heart failure and diabetes. Pointer is not working. It's not working. So let me start with a brief case. A 54-year-old woman presented with shortness of breath for 4 months, and shortness of breath has progressed over last few days to almost daily activities, and even while sleeping she uses 3 pillows to be comfortable because moment she's lying flat she gets breathless. There is a history of hypertension, dyslipidemia, type 2 diabetes, and of course history of CAD in the past. 4 years ago she had CABG. She is on standard care, aspirin, atorva, telmisartan, bisoprolol and metformin, and there is no significant social or family history as related to her symptoms like heart failure. So this patient was investigated. She had bilateral diffuse crackles in the lungs on examination. JVP was up. A anti-pro-BNP level was 874. Troponin level was normal, and an echo revealed that ejection fraction is less than 33%. So this is typically what is a reduced ejection fraction heart failure. Another situation, 60-year-old female, she's a non-alcoholic and non-smoker. She has diabetes for 10 years and hypertension for 20 years. And on probing, she again comes out with history of breathlessness, progressive over last 6 months. And she's again on standard treatment for diabetes and hypertension and on statins. Again, XHS has revealed a cardiomegaly. Anti-pro-BNP is mid-range, it's not very high, not more than 750 or 800, and echocardiography has shown an ejection fraction 46%. This is what is typical a mid-range ejection fraction heart failure. And the third situation is an old 82 years old woman with long-standing hypertension, obesity, type 2 diabetes, presents again with history of exertion, dyspnea, which has increased over last several months. She has bilateral pedal edema, and again she's on standard care. And this is how 3 different forms of heart failure, more so in the setting of type 2 diabetes, they can be independent also. I'll be discussing those situations can present. So let me take you through how heart failure, it comes as a comorbidity, one of the most common comorbidities in setting of type 2 diabetes, and accounts for a significant morbidity and mortality despite advances in treatment. What has happened over last 20 years or so. Paradigm heart failure said that CV death and hospitalization heart failure are very, very high despite optimal therapy, and rate could be as high as 22% at 27 months. That means within 2.5 years, mortality may be very, very high. Even the rate of CV death was 13.3%. So it has been said that heart failure probably may be as bad as any other malignancy, where prognosis we assess over 5 years time, because all cancers, they carry a very, very poor prognosis over 5 years, close to having survival rate less than 50%. So is heart failure. So it is probably having a situation almost similar like having any other malignancy. So heart failure and diabetes, unfortunately, is one of the most common cardiovascular complication. It is most disabling also, and deadly complication of diabetes. And many times there is a subclinical heart failure which may manifest over 5 years time. And then the effect of glucose lowering drugs are different absolutely when it comes to management of heart failure with type 2 diabetes as a comorbidity. Of late, heart failure staging has been revised. Earlier days, in our college days, we were talking on NYHA, class 1, 2, and 3, and 4. Now it is graded as someone having a structural disease or not having a structural disease, as A, if there is only clustering of the risk factor. B is when there is a structural heart disease but no signs, symptoms, or presence of heart failure. C is when there is a structural heart disease with prior or current heart failure in situ. And D is when there is a refractory heart failure requiring specialized intervention. And this is what we earlier used to talk about NYHA class 1, 2, 3, and 4. 4 means there is a refractory and stage heart failure, more so in the setting of type 2 diabetes, classically presenting with type 2 diabetes. Eric study said that if you talk about modifiable risk factors to reduce the burden of heart failure, probably it is diabetes which accounts for highest numbers of hospitalization with heart failure. So even if you modify all other risk factors like smoking, elevated LDL, hypertension, or obesity, still the risk for developing heart failure is very, very high in the setting of type 2 diabetes. And a beautiful Lancet editorial talking about war against heart failure in this, that there has been significant reduction in myocardial infarction over last 10 years, morbidity, mortality, case fatality rate or event rates. But when it comes to heart failure, there has not been any change. Actually, mortality because of heart failure is still going up even today with best of the management what is available. So heart failure is probably one of the most common causes of CV related hospitalization in even USA. When it was screened over almost 15 years time, whether it is men or women, you could see that heart failure is on the top of all other diseases, even if it is versus acute coronary syndrome, cardiac arrhythmias, ischemic stroke, or hemorrhagic stroke. Heart failure hospitalization accounts for highest numbers of admission. Even the Caliber program said that heart failure and peripheral artery disease are probably one of the most common initial manifestation. There's not a small data, close to 19 lakh patients, those who were absolutely free of CVD, and they were then followed. Only 1.8% out of them, they were having diabetes, and they were followed over 5.5 years. 1 lakh turned out to be having some manifestation of CVD over 5 years. And in that, almost 50% patients, 5% patients were only having type 2 diabetes, but in them the most common first manifestation was PAD and hospitalization with heart failure, accounting for almost 1/3 of the cases. Non-fatal MI was down, and even ischemic stroke was less. But unfortunately, when we talk about CV outcomes, we are not still accounting for primarily hospitalization with heart failure amongst 3 MACE points, nor even PAD, although these are one of the most common manifestation of higher CVD risk or maybe morbidity and mortality. Even the Swedish National Diabetes Registry said that the risk for developing heart failure, even if you try to correct everything, you get back sugars within the normal range, bring down LDL in the target range, so is about albumin-creatinine ratio, make them non-smoker, and try to control their blood pressure. Everything can reduce risk overall of CVD, but when it comes to heart failure hospitalization or a composite of CV, death, and hospitalization with heart failure, that risk still remains very, very high in spite of the fact that you have already accounted for all these factors within the normal range. So probably there is a sharing link, there is a common soil hypothesis between type 2 diabetes and heart failure, which both induce endothelial dysfunction, insulin resistance, mitochondrial dysfunction. There is an overactivation of RAS and inflammation, and then increasing the risk for heart failure by impaired contractility, cardiomyocyte apoptosis, fibrosis, neurohormonal activation, and LV remodeling. So the pathophysiological base mechanism of diabetes which could contribute towards the development of heart failure is probably based on hyperglycemia, persistent insulin resistance, and hyperinsulinemia. Through atherosclerotic cardiovascular disease mechanism, it leads on to typically an ischemic cardiomyopathy. If you have a comorbid hypertension, there is a greater risk for developing hypertensive cardiomyopathy. But even through microangiopathy, through metabolic disturbances, or through disturbed cellular function, or through cardiac autonomic neuropathy, or through overstimulation of RAS system, it sets on the stage for a diabetic cardiomyopathy, which is typically a microangiopathy. So heart failure in diabetes could be either an atherosclerotic based mechanism where there is a typical reduced heart failure, and it could be a preserved heart failure because it is through non-sclerotic independent pathway, which are inflammation through reduced natriuresis, increase sympathetic overactivity through overstimulation of RAS and these mitochondrial mechanisms. So heart failure in diabetes, as I told you, it could be a preserved ejection fraction, it could be a reduced ejection fraction, or it could be a term which is very recently coined over last 5 years. It could be a mid-range heart failure, again accounting for very high cardiovascular mortality. And unfortunately, heart failure is very, very early and if forgotten complication in setting of type 2 diabetes. If you follow these patients over 5 years, since the diagnosis, 68% of patient will have one or the other manifestation of heart failure, either in the form of preserved or maybe in the form of reduced ejection fraction. Not only that, if you screen patients with any typical cardiac screening program, 28% of these patients you will find they already have undiagnosed heart failure because their symptoms are not much, so it could be missed. So when it comes to adverse heart failure prognosis or outcomes, probably diabetes at almost at the high risk for developing morbidity and mortality because of heart failure after age and sex, which obviously you cannot modify. So it comes much higher than even having a higher creatinine or presence of diabetic nephropathy or smoking or hypertension. And again, it has been seen that mortality improvement, as I said earlier also, over last decade or two has not improved in spite of the fact of standard care, although it has significantly come down with major cardiovascular disease with intervention or even with stroke. But once it comes to heart failure, hospitalization or arrhythmia, mortality still remains very, very high. So let's talk about how we can reduce hospitalization with heart failure. The new backbone of heart failure today probably is we start with RAS inhibition, beta blockers, MRAs, which are now available, and SGLT2 inhibitor. And let's see the evidence whether adding an SGLT2 will do some benefits in these patients. So a potential framework for identifying patient without baseline heart failure or atherosclerotic cardiovascular disease who may benefit from SGLT2 when it comes to screening and then opting for the best drug for these patients would be whether these patients are on an insulin, sulfonylurea, DPP4 or TZs where the risk of heart failure is high. If they have comorbid situation like hypertension, obesity or atrial fibrillation, again the risk for heart failure is very, very high. And if they have non-cardiovascular risk factor like increasing age or obstructive sleep apnea, again the risk of heart failure is high. So best is performing a anti-proBNP. If it is less than 50, probably they just need to be monitored. If it is already more than 125, that is the point we should add SGLT2 preferably. But if it is already more than 125, I think that is the perfect state. We do an echocardiography, look for ejection fraction, and immediately start these patients on SGLT2 inhibitors. So the four pillars of management of reduced ejection fraction to reduce mortality in all these patients will be adding an ACE, ARNI, beta blocker, MRA, and SGLT2 inhibitor. And let's see what is the current evidence, whether in terms of reduced heart failure or preserved heart failure. There is a very good study, Emperor Reduce study, almost 3,700 patients, they were versus placebo, and they were followed for a total duration of almost 1.5 years. Primary outcome was obviously CV death or hospitalization with heart failure, and there is a 25% risk reduction, which is p-value wise very, very significant once these patients are on empagliflozin versus placebo therapy for reduction of hospitalization with heart failure and mortality. Another study, that is Emperor Preserved, where these patients had ejection fraction more than 40%, close to 6,000 patients, again randomized to EMPA versus placebo and followed for a total duration of 26 months. And again, you could see that those patients who had mid-ejection heart failure with LV ejection fraction between 41 to 49%, there was a 29% reduction in CV death or hospitalization with heart failure. And those who had a preserved ejection fraction, more than 50%, even there, adding a drug like SGLT2 inhibitor could reduce the risk of hospitalization with heart failure or CV death by almost 17%. Even EMPA response, that is an acute heart failure, if you start this drug, a short data of 80 patients has shown that there could be a reduction in endpoints of in-hospital worsening of hospitalization with heart failure, re-hospitalization for heart failure, or even death at 60 days compared to placebo, even if it is a acute heart failure setting and a drug like EMPA is started immediately after the onset of heart failure right inside the hospital. Even DAPA heart failure has shown that DAPA on worsening heart failure and risk reduction in terms of CV death or composite of CV death and hospitalization with heart failure has gone down to 26%, and even hospitalization for heart failure or an urgent emergency need for a hospitalization has gone down to 70%. So all the outcomes are on the left side, close to 20 to 30% reduction in composite endpoints. And I'll not be able to go into the details of all these studies, but a summary of all studies in recent heart failure event, whether it is Solist or Galactic or Victoria or Pioneer or Impulse, all these have shown that there is going to be an improvement in hospitalization with heart failure with drugs like SGLT2 inhibitor when it is a reduced ejection fraction. Well, preserved ejection fraction, EMPA, I have already shown. Again, there is a reduction in composite endpoint, CV death and hospitalization with heart failure, irrespective whether you're a diabetic or a non-diabetic. With a drug like SGLT2 inhibitor, there is going to be a reduction in composite endpoints, because with SGLT2 inhibitor, not only there is going to be a reduction in afterload, there is going to be a significant reduction in preload with diuresis, natriuresis, glycosuria, and reduction in proteinuria. And then you have ATP mediated usage of beta hydroxybutyrate as an alternative source of energy by the myocardium, which preserves myocardium even during a phase of acute coronary event. And we know with SGLT2 inhibitor, there is going to be a vasoconstriction of afferent arteriole. So there is going to be reduction in intraglomerular pressure, which then gets all the benefits even in the form of reduction in proteinuria and hospitalization with heart failure. So when we talk about patient-centric tailoring of medical therapy in reduce ejection fraction, the current position statement in 2021 talks about the drugs like SGLT2, beta blocker, ACE, ARNI, MRA, and diuretics. And irrespective whether there is a normal blood pressure or a high blood pressure, whether there is a presence of atrial fibrillation or no atrial fibrillation, presence of CKD or no CKD, or depending on the pulse rate, everywhere if you add one drug like SGLT2 on top of the care like ARNI, diuretics, and beta blocker, you are going to reduce CV composite endpoints and hospitalization with heart failure. So today the step one is you add beta blocker to reduce pulse rate, and then immediately add SGLT2 inhibitor right in the beginning, even maybe before ARNI or even before MRA. And this is how the algorithm ideally should be followed. This is by American Heart Association, and it came in 2021. So to sum it up, even the DAPA heart failure trial said, a beautiful editorial appeared by Subodh Verma, that it is a momentous victory in the war against heart failure when we talk about standard care in management of heart failure, irrespective whether you have diabetes or non-diabetes. The pillars are ACE, ARB, beta blocker, MRAs, ARNI, and of course there it was dapagliflozin, because it was inspired based on the evidence from DAPA heart failure. I have already shown you EMPEROR reduced and preserved and acute heart failure with empagliflozin, and results are exceedingly very overwhelming, almost close to 30 to 35% reduction with any class, with any drug in the class of SGLT2 inhibitor. So to sum it up, heart failure today should be reviewed or should be considered a syndrome rather than a disease, because it is sum of so many things. The condition means the heart is unable to pump enough blood to meet the needs of the body. The leading causes in the developed world are ischemic heart disease and hypertension along with diabetes. And the clinical diagnosis is based on clinical assessment, history, taking signs and symptoms. I've shown you 3 cases in the beginning. I won't go into the details. Laboratory depending on NT-proBNP today, and of course proving it with 2D echocardiography. And today SGLT2 is approved for all patients with symptomatic heart failure, irrespective how much is the ejection fraction, whether it is mid-range, reduced, or preserved ejection fraction. It significantly reduces the risk of CV death and composite of hospitalization with heart failure, irrespective whether you have diabetes or you don't have diabetes. And what are the background drug? On top of that, adding SGLT2 will further reduce risk by close to 30%. It will improve quality of life. And fortunately, drugs like SGLT2 inhibitor, these days are very, very competitively priced, and these are very well tolerated. Thank you very much for your patience listening. You have any questions? I'll be more than happy to answer that. Yes.
Any questions?
Sir, I wanted a very nice lecture about heart failure. I wanted to ask about chronic heart failure. What should be the level of NT-proBNP in a chronic heart failure state with a preserved ejection fraction?
If it is a preserved heart failure,
Preserved heart
preserved will
failure.
have near normal NT-proBNP. It will be, ideally it will be less than 125, anything between 50 to 125. But even preserves are known to go into acute heart failure where NT-proBNP may go up transiently, but that might be because of accelerated hypertension, any stress, any risk of sepsis, or any acute worsening that can put even preserved heart failure into acute heart failure, and they come back to again with a ejection fraction.
So there is no difference between acute and chronic heart failure NT-proBNP value.
See, NT-proBNP in a chronic heart failure will stay on the higher side. If it is an acute heart failure, it will go up. This is what we see every day in hospital. We repeat after 7 days with diuretic, beta blocker, SGLT2 inhibitor, and couple of other standard care, and it immediately settles down with a normal range. But then NT-proBNP are huge ranges. Anything more than 750 is typically very, very high.
No, if suppose patient is having 350 NT-proBNP with preserved ejection fraction,
Yeah.
concentric hypertrophy.
In acute, it will go up, but then it will come back to normal. If it is a chronic heart failure, NT-proBNP may stay on the higher side.
So how to detect? What to tell patient? Patient is having 350 or
See,
375.
you do an NT-proBNP,
Okay.
and you do a 2D echo. If ejection fraction is normal, it is more than 50%, it is preserved heart failure, but still NT-proBNP may be up. If it is between 40 to 50, it is mid-range ejection fraction, less, but then even ejection fraction also moves across the spectrum. Anyone having preserved heart failure may come with acute diastolic heart failure, typically even with accelerated hypertension, may have ejection fraction now less than 40. Within 2 weeks with standard therapy, it comes back to normal. So I think there is no need to classify on day one that whether you are having a preserved heart failure, a stable heart failure, or mid-range or reduced heart failure.
Sorry to
That
interrupt.
will
My
ultimately be
question is-
classified once patient is hemodynamically stable.
No, that is what my question is. If patient is having 350
I think-
of
I think-
NT-proBNP,
I
should
think
we
we can
label him as
discuss
a
it.
chronic heart failure?
Sir, I think that we can discuss
Anti-
it on the floor because we need to start the next session. Meena Chabra ma'am, very quickly.
In an
and then we
acute heart failure, there is no way that you'll be able to classify that this patient will finally settle down to preserved, mid-range, or reduced ejection fraction. Yes, Dr. Meena.
Dr. Chavla, my question is when in the ICU we are called to see a patient as a diabetes specialist, when do we start the SGLT2 inhibitor?
As early as within 3 days.
3 days we are not.
Yeah, within 3 days, moment patient is hemodynamically stable. Someone who is hemodynamically not stable on positive ionotropes, on very high doses of loop diuretics to reduce preload and afterload, obviously day one you will not start. Within 48 to 70, dictum is at 72 hours, once patient is hemodynamically stable, we start them on
So,
SGLT2
Dr.
inhibitor.
Chavla, my question is that we've also done a study. We haven't published it yet. We are 15 of us, and we've seen as high an incidence of genital tract infection, not urinary tract, in our patients. Particularly as a women diabetologist, I see more often. So my question is, in heart failure, when you really want to give SGLT2 and the patient has history of recurrent GTI, would you still like to give it and give an antifungal, or it's better to avoid it?
See, in acute, maybe fungal sepsis, That is what I said, hemodynamically stable. All these patients, if you are in hospital practice, when they are in ICU, intensive care or in cardiac care, they are not going to be very stable patient. Many of them, they have fungal urea, they have positive culture. These days we are getting 5 drug sensitivity, which comes out to be on very high drugs. Even Siscan and voriconazole will not do anything. Those unstable patients, those who are already on inotrop, those who are in still acute heart failure will not be the right candidate for immediately starting SGLT2. Wait for 3 days, maybe up to 7 days. Let them stabilize, let their fungal urea settle down, and that is the time you may start before discharge. This small data of 80 patient in acute heart failure, still I don't find is a guidance that even if patient is in acute heart failure and day one you start SGLT2, common sense says, our own clinical prudence says that let patient be hemodynamically stable. Out of sepsis, patient is already on very high antibiotics, TLC is very high, or there is a fungal urea. There's no point that you will add SGLT2 and put them at a greater risk for sepsis.
Perfect. So thank you so much. It was a superb session. I would like my chairperson to introduce the next session.
Thank
You so much,
Uh,
Dr. Chawla.
Thank you, sir, for the insightful session.
Thank you.
I would like to welcome our next speaker, Dr. Hemal Shah. Over to you, sir.
Thank you, Shruti. A reverberating discussion there. And Madam, I'd like to just simply add about the UTI and SGLT2 as a nephrologist is do look for correctable causes, look at the bladder output, retention, and that again would be helpful. If you correct that, they are able to tolerate the SGLT2s better. Okay. Coming to my talk about the MRA and what today, where do they stand, and how do we position them in our clinical practice? I think this is something that I don't need to introduce to this audience. We are facing a pandemic of diabetes in our country, noted to be about 77 million. And I think all of us will agree that these are extremely under-reported numbers. And this is going to continue to rise. As we can see, the number is going to probably cross 100 million in another 5 years. This leads to another pandemic of kidney disease, wherein if you see about 40% of these diabetics have chronic kidney disease. Again, we all know this is extremely underreported, and that I will be bringing up these points in due course. But by and large, 2 out of 5 adults as of 2019 in India have chronic kidney disease due to diabetes, and this is an overwhelming number when you are talking about 1.4 billion people. I spent my first decade after coming back from North America popularizing the fact that please calculate eGFR. And while we've all got used to looking at eGFR over and above creatinines, just creatinines, we are here back to confuse you, saying that please don't look at only eGFR, at UACR. And this is something that it's being urged at all levels, and particularly primary care. I'm sure I see a lot of diabetologists obviously doing this very regularly, but because diabetes, there are multiple primary care also handling these patients. It becomes very important to today recommend that add UACR at least once a year. We see big files of sugars done over years, and then suddenly they are referred to us and we start diagnosing them with a A3 as far as the proteinuria is concerned, and we talk about GFR urine 3A, and then the patients are asking us that how come doctor never, when my 50% of my kidney is gone, how come nobody even looked at it? And that's when it's embarrassing. So I urge you to at least do it once a year to document the fact that the kidneys were normal. And then, of course, when they're abnormal, you can go back to that. So very important that your diabetics stay in the green zone. This is something that I think I use very often. I actually plot the patient's condition in this, like we show them that where they are. So we make sure that they know that they are somewhere in, so which exactly which zone they are in, and if they are moving towards from the green zone, that is the top left hand corner towards the bottom right hand corner, this makes them far more, uh, they respond far better to all the therapies and the interventions that we are talking about. And therefore, EGFR calculated either the labs, many labs are giving it, and UACR, or you calculate the EGFR with your smartphone. This is where we need to put these patients. Now you have a person, till now, as I said, we were doing only EGFR. Now this guy, if he was having a proteinuria which was less than 30, a UACR less than 30, he was in the green zone. But now if you do his UACR and it's more than 300, he suddenly shifts into an orange zone. So this is the importance of this heat map, and I think this needs to be used in every patient. Probably we can in fact make sure that the patients themselves place them on that continuously. Now the timeline is very important, because as diabetologists you get enough opportunity to prevent kidney disease. So you have the whole diabetes problem starting up front, and then you have the preclinical stage where the GFRs are actually normal and the proteinuria starts climbing at that stage, and then subsequently the albuminuria will go on increasing, the GFR will start falling, and this is all related, when proven very well, that this is the point where the fibrosis starts occurring in the kidney. And at this point we are still able to control this. Is there a pointer which I can use? So this is the point where there's enough opportunity of almost 25 years we are getting to prevent kidney disease. Now, because this, and so that is the reason why all these agencies, where you talk about ADA, you talk about KDIGO, which is the nephrologist Bible, and the other American Cardiology Association, everyone are recommending that at least EGFR and UACR should be done once a year, and I think this is something that I highly recommend. Now, there is a price you pay for late diagnosis, and this is as very clearly seen here, that when a diabetic patient starts deteriorating in terms of albuminuria and GFR, the MI cases are 2x, the heart failure increases by 5x, there is a higher chance of 5 to 6 times higher hospitalization that occurs, and of course all this leading to a 3 times higher cardiac death. Similarly, when you have higher ER admissions, inpatient admissions, and dialysis, of course, will go up by 4 to 40% depending upon the trajectory of those, the heat map that we talked about. Now, how can this be stopped? So we do have enough data now and enough ammunition in our armamentarium to help these patients. So we do know it's common, we do know it's preventable, we do know that they give us enough time to intervene and do something about it. Now what exactly do we do is what we are looking at. I think historically low protein diet and ACE inhibitor ARB we know for the last 30 years and plus. So that is the first interventions which we know since, low protein diet since 1980s and ACE inhibitor ARB since the 90s. We know that they take care of the hemodynamic intervention which prevents kidneys, and they reduce kidney disease by 50%. So this was huge interventions. Then unfortunately there was a drought between, for 30 years we had no new intervention available, and it is in the dark ages of COVID that data started pouring in from the SGLT group. I think Dr. Chawla has mentioned about the heart, but I cannot undermine the benefits that the kidney also derives from the SGLT2 group. I think all of us know that, and thankfully now very rarely do we see a patient coming to the nephrologist without an SGLT2 already there. From, of course, the endocrine and diabetology community are very well versed with this, but even primary care, I'm seeing that they are also using this drug quite aggressively. So that again is helping not only with the hemodynamic because of the afferent arteriolar action of the drug, but also helps with the metabolic. The metabolic, we all know, we need to keep the sugars down to prevent hammering of the kidneys. And of course, SGLT2 adds significantly to that as well. But the third aspect was relatively, though known, but we did not have an effective drug available for this, and that is where the new available medicines are helping, and that is the inflammatory changes that occur because of this damage that the sugar is doing. And we do know, we knew for decades that the mineralocorticoid action is responsible for this fibrosis, and therefore I, for one, have been using spironolactone from early on, and eplerenone in the last decade, and of course now there are some other benefits that we are seeing. So how exactly finrenone kind of helps us with this is that it kind of overcomes certain shortcomings of the previous generations of the MRAs. Of course, we knew that the MRA blockade is going to help prevent inflammation and fibrosis. It also benefits with the hemodynamic effect, and there are some metabolic benefits as well. And the benefit of the drug is equal for the heart and kidney. That is literally you're killing one arrow with two targets, there. Now, how is this drug different from what is available till now? The biggest two differences that I will point out is the half-life of the drug. Spironolactone more than 20 hours, eplerenone 4 to 6 hours, and finrenone is about 2 to 4 hours. And this action of the drug latching on to the receptor and then even releasing is the one that reduces the hyperkalemia that we normally associate with spironolactone. Spironolactone was a brilliant heart failure drug, and I remember when I was in Canada, my own emergency room department had published a paper about the increased number of visits of patients coming to the ER because of hypokalemia, and that is where spironolactone lost out, and the benefit that the drug does give to the heart and kidney could not be translated into clinical practice for the same reason. So therefore, the newer drug is helping us do that, and this is primarily because we are able to continue the drug without hypokalemic responses. To point out some important differences here, again, spironolactone does cause gynecomastia, and most men will not complain about it, but the ones that you actually go down looking, if they've been on it for a long time, you will see that it definitely is there, and that becomes a big problem. So hyperkalemia, again, I have told you, let us not forget that we are a predominantly vegetarian country, and therefore controlling fruits and vegetables which are high in potassium is challenging to keep them well nourished on the other hand, and therefore any drug which is causing hypokalemia in a scenario where you're talking about already the patient having a compromised kidney function, which again is going to cause increase in potassium, becomes challenging. Therefore a drug, and also do not forget that these patients must be on ACE inhibitor or ARB for the best results. Therefore you're adding a drug which can cause hypokalemia, it becomes important to choose something lesser. Let me move on to some of the clinical data that is available to us. Now, based on what is current data, there are three, just as doctor talked about the pillars of heart failure, we are talking about the pillars of preventing progression of kidney disease. You have the RAS blockade, as I mentioned, from the 90s. You have the SGLT2, which has become a blockbuster in the last 4 or 5 years. And now you have the mRNA blocker, mineralocorticoid receptor antagonist, which is again in the form of finrenone being added to that, forming a respectable triad. Now, among all the drugs that have been researched, the most robust data comes from finrenone, and that is one of the reasons why we are so confident of trying to recommend this. As you can see, the number of patients studied here literally doubles that of all the other major studies that have been conducted in the milieu of chronic kidney disease. Now, the big advantage, the Fidelio trial was for 5,700 patients, which looked at the yellow and the orange zone predominantly as far as the heat map is concerned. And therefore, any patient who is in this zone, in sitting in front of you, then this drug, the results of this trial will be valid on them. The Figaro, in addition, looked at little lesser involved as far as the renal parameters were concerned. And therefore, the combination of these two will tell you that almost all your patients with any albuminuria or any compromised GFR, that the study data is going to be easily generalizable onto them. And this is what the Fidelity trial gives us. It is a pool data of these two trials. And this is the entire population of patients who should be on this drug based on that, like stages CKD stage 1 to 4. And this is where, if you talk about a typical patient, like the one I started off with, who has significant albuminuria, with almost beginning to start having a fallen GFR, also qualifies for this. So Fidelity looked at type 2 CKD patients, primary pooled, and all of them had a serum potassium less than 4.8. And in addition, they looked at as far as the composite endpoints are concerned, one was cardiac ones and the kidney, to not only going on dialysis, but reaching advanced kidney disease. Now, so all of them, 99.8% of them were on ACE inhibitor or ARB. It's a very important fact that that is still the number one drug that needs to be added. Pressures were well controlled, target pressures down to 137 by 76, maybe another 5-10 points lower is what the KDIGO guidelines suggest. So something to look at. But interestingly, here, if you look at the data, the middle column, the SGLT2, the only 6.7% of the patients were there, because do not forget that this was data which is published before the SGLT2 data came out. Of the trials did not include these or did not make it mandatory. So a very small amount of patients were on the SGLT2. If they were to do the trial today, all of them would be on SGLT2. So this is the little difference here. Now, despite that, despite SGLT2 not being there, so in a way it's good, because this gives you pure the action of findenone on these patients. So there's a 23% reduction in the kidney outcomes and 20% reduction in the reaching of end-stage kidney disease. And this would be robust. When you talk about this, you're actually postponing dialysis. If you're getting this kind of a reduction, you're almost giving them 4 or 5 years of dialysis, giving their kidneys a longer life. So this is what is a very significant intervention. And this translated into a CV morbidity mortality reduction of 14% and heart failure improvement by 22%, which has already been alluded to. This is on basis of the UACR dropping by 32%. And this tells me that very early intervention in patients who are proteinuric, albuminuric needs to be done so that they stay stable on that heat map, or even move towards the left upper end corner, maybe even from the yellow and orange zone into the green zone, where still the GFRs are not compromised. As I mentioned, the SGLT2 was not there, but when he looked at the patients who had both, there was an even further robust reduction. There was a 31% reduction in the UACR, and with the without the SGLT2, which moved to about 37% with SGLT2, so suggesting that these drugs synergistically move forward. This studies also looked at the biomarkers, which could now very well be the troponin I's as far as the kidney disease are concerned in the years to come. And this was the WNTA9A, a very significant biomarker, which tells you about the fibrosis occurring at the kidney level. This was used in Figaro, and the other one, which was NPY, which was used in the trial where they looked at and this was specifically for the aldosterone secretion. So these again in the future, I think will come up as clinical use parameters, which we can help look at actually the fibrosis, which is such a difficult thing to judge without any parameter like this. Now, combination of this, when you look at the clinical data, translates into, when you give SGLT2 and MRA together, you're going to add a significant number of years from kidney failure and mortality. Now, let me just give you an example, something that all of you will reverberate with, is that suppose there is a patient who comes to you with a GFR of 50, and you're doing all these interventions that we are talking about, using all low protein diet and MRA and SGLT2 along with the RAS blocker, keeping your sugars under control, BP under control. Yes, very difficult, but if you can do that, then your fall in GFR could drop as much as 1 to 2 ml per year versus about 4 to 5 ml per year. So if a 60 ml GFR patient comes to you, he's going to cross 15 ml, which puts him into the dialysis range. So 45 ml GFR will fall in 9 years if his GFR is falling at 5 ml per year. But with all these interventions, if it goes down to 2, that 9 years can be extended to 22 years. So if you're talking about a 60-year-old in this scenario, if you're going to give him 22 years of dialysis and reaches 80, 82, at that point of time, he can decide whether he really wants dialysis or he's lived his life. So this is the importance of preventing them from reaching the dialysis unit early on. Otherwise, at 69, he will not only have a few years left, he will go on dialysis, land up with a lot of morbidity, but also financial losses there. Now, again, when we talk about the last pillar that we still talk about is the GLP-1 RA. Again, that is something that you know more than me, but again, that bringing down the HbA1c will be another important intervention as far as the kidney parameters are concerned. Now, let us see whether the patients can tolerate all this. You know, when you keep adding it, Madam already discussed about UTIs, but what about the hyperkalemia that we talked about? But here, as you can see, that most of them, the significant side effects were noted in only a minuscule number of patients. And in fact, any hyperkalemia was about 14% versus 6.9. And this will happen. Potassiums will change because the mango seasons will come. And despite giving them warnings, despite giving them diet consults, there will be indiscretions, which, the things will go up and down. But main is whether we are able to control it. Is it significant enough for them to visit a hospital? And all those were significantly lower with Finridone, actually suggesting that this drug can be seamlessly continued over a long period of time. So when we talk about the final, condensing the data, 22% of reduction in heart failure, 17% of death, and 32% of new onset heart failure, something already been discussed. And as a result of this, as I mentioned, various clinical guidelines, Finridone has made its way up very rapidly within the couple of years of its launch. So definitely something that we need to look for. Looking forward, there is more data to come out, and you have the Thunderbolt and the Moonraker for kidney and heart respectively. And today, I believe at 2:30, there's more data coming out as far as chronic kidney disease is concerned, multiple trials going on, and we look forward validating what we're seeing scientifically already here. Now, I myself did a 20-patient study, and here again, this was just a prototype. This patient was in the yellow zone, as you can see, with a GFR of 53 and 105 proteinuria, albuminuria. And again, this patient, well, similarly, I will just quickly, this patient seen after 3 months, there was a 49% reduction in the UACR without any real change in the potassium. This is again part of the series, 20 patients, again, age between 52 and 68, about 10 to 22 years of diabetes. 10 of them had history of cardiovascular disease in various forms, 18 of them hypertensive, HbA1cs were still not ideal, blood pressures were good, the eGFR was significantly compromised in 50% of them, and again UACR, there was a wide range from moderate to severe. And
So I think
these patients will, if you look at it, 18 of them were on SGLT2 and the other standard medications, and as you can see the UACR chart, each of them showed a very significant reduction within the first 3 months without any change in potassium, suggesting that they tolerated it well. Now here again, very quickly to summarize, that I personally look at their potassium, start them on 10 milligrams, if the kidney GFRs are compromised significantly, that is 3A, 3B. If it's stage 2, very rapidly move them to 20, and the others within 3 months, I will try to push them to 20 milligrams. Again, there are 5 Fs, so just make sure that the potassium doesn't cross 5. Make sure you give the dietary advice along with that. When GFR is below 25, be careful. Then, and as I said, we look at we start at 10 and increase it to 25. I think with that, I'll be happy to take any questions if there are any.
In interest of time, we are running 15 minutes late, so we'll be discussing everything, but on the floor, so that we hand over the sessions for the next.
Thank you, sir,
so
for the illuminating session.
Thank you. So we conclude this session with Rajiv Chawla sir and Abel Shah sir. The fire in the kidney that we talked about, I think sir has concluded it. So we start with the next session. Over to the organizers for the next session. Thank you so much, Rajiv Chawla sir. Please collect your moment to. Thank you, sir. It was a pleasure.
You all can
I
take one
request,
picture with all the.
Rajiv Chawla sir and Abel Shah sir to be on stage for the formal photograph. And the next session, the speakers and the chairpersons, please be ready. I think Srinivasan Murthy sir is outside.
Dr. Srinivas. Thank you, chairpersons and our honorable speakers. We now move on to our next session, special situations in clinical practices. I would like to invite our chairperson, Dr. Nitin, Dr. Brito, and Dr. Hansa. Over to you, sir.
Good morning all. So this session we are going to discuss regarding the special situations in diabetes. So regarding diabetes management and hypertension in diabetes, most of the time we think of ARBs, dipins, and then diuretics, and at the end we are think of beta blockers. But now we have a speaker, Dr. Ketan Mehta. He is going to speak on regarding the role of beta blockers across the CV continuum in diabetes. So Dr. Ketan Mehta is the president IMA Mumbai West and honorary secretary of IC. So vice president of IMA, organizing secretary of ACCON, and so many things. Postgraduate teacher he is. So he's a well-known speaker in all the conferences. So over to you, sir.
Thank you. Very good morning to one and all. A respected chairperson, thanks for those kind words. And of course, my special thanks to DRS team, my dear friend Manoj Purvi, and the entire team for inviting me over here. The topic given to me is role of beta blockers across CV continuum in diabetes. And then as rightly pointed out by chairperson, that, you know, when it comes to beta blockers, everybody thinks we know everything about it. And that reminds me the beautiful quote from Sir Isaac Newton, who states that what we know is a drop, what we don't know is an ocean. And that is so much true when it comes to talking about the beta blockers also. Now, you know the CV continuum. CVD is prevalent in a large, rampant way across the globe. And experts have hypothesized that there are various risk factors which will lead finally to end-stage heart disease. So this series of events, if you see over here, which is in even starting with just a simple risk factor like hypertension, and then you will have the plaques, you have got a ischemia, you can have an infarction, then you have a heart failure, and then the end stage heart conditions which is there. And that is one which can be the detrimental, which we know it. So we know that death is inevitable, but premature death is not, as said by Sir Richard Dole. And that's what we are all here. How can we prevent the premature deaths of? Now, if you look at in diabetics population, diabetics per se does not kill a person. What are the common causes of death? So again, number one cause is coronary heart disease. So that is one thing which is the main thing, and how we can prevent it. The previous speaker has already spoken about kidney failure, hypertensive disease, which are the other causes which are there. Now, talking about the beta blockers, there are various actions of beta blockers which are there and which are a positive effect on a person, especially with diabetics. So it has a negative chronotropic effect, it has a negative dromotropic effect, anti-arrhythmic effect, negative inotropic. Now here this thing, it may be not always detrimental, it will have a positive impact, and also anti-ischemic effects also. Now, we know how the beta blockers have evolved over a period of time. If you look into the various classifications, if which now we know that we are always looking at the newer and newer generations of beta blockers. Gone are the days where the first generation non-selective beta blockers which were used like propranolol. So you have a second generation beta 1 selective blockers like atenolol, bisoprolol, metoprolol used. And then now you've got even a third generation vasodilatory beta blockers. Again in that non-selective like carvedilol and labetalol, and beta 1 selective specifically in that nebivolol. So you have got the basket where you can choose the which beta blockers which you will be interested in using. So now this is a very important point, talking about the heart rate. You know, you talk about any gadgets also. If you have your BP instrument, digital one, you have besides BP, what is there? Your heart rate. If you talk about the pulse oximeter, so besides oxygen saturation, what is there? Heart rate. Now, heart rate has got an important point, because increased heart rate is a long-term predictor of cardiovascular events in a patients with hypertension. So remember, this chart is beautifully shown that if you talk about the heart rate and blood pressure, so obviously high heart rate and uncontrolled blood pressure is the most dangerous thing, and the low heart rate and the controlled blood pressure is the most welcome thing. Now, if you have to choose between heart rate and blood pressure, look at this data, what it shows, that high heart rate but BP controlled is more detrimental than low heart rate with uncontrolled BP. Now, that is one thing which we have to keep it in mind. So, let's look at the prognostic role of resting heart rate in cardiovascular disease. Now, if you see this continuum of cardiovascular disease, the heart rate has got an impact not only on risk factors, that means it has an impact on hypertension, atherosclerosis, ischemia, but it has also results into the end stage effect, that is having the loss of cardiac contractility, dilatation, remodeling, heart failure. So it has an effect everywhere, and that is where you are always targeting for control of heart rate. So if you look this continuum of cardiovascular disease in role for beta blockers, so whatever labeled in blue has got impact through beta blockers. So whether we talk of hypertension, we talk of LVH, coronary artery disease, myocardial ischemia, myocardial infarction, neurohormonal activation, various arrhythmias, even effect on sudden cardiac death, remodeling of heart, ventricular enlargement, congestive heart failure, and death. So you have got the effect and impact across the CV continuum which has been seen over here. Now, all beta blockers are not same. So obviously we know that there are differences of pharmacokinetics and pharmacodynamics amongst the various beta blockers. The bisoprolol, which is one of the most favorite one nowadays, which has got now advantage with bisoprolol is it is of course the low lipid solubility, and it has got a dual elimination, that is renal and hepatic, and has got highly selective beta 1. So that is where you have a scoring of bisoprolol over the other molecules also. Now, when we talk about pharmacology, there was a time when beta blockers and diabetes was like big no-no. And UKPDS 39 had shown that there was no differences in the rate of minor or any major hypoglycemic episodes, even in patients treated with atenolol. That was the molecule which was studied amongst beta blocker. And even that has shown no significant difference even when compared with the captopril. So you know that it is whatever was that, this is predominantly a myth. Carvedilol, which we know is less likely than other traditional beta blockers to worsen insulin sensitivity in a patients with diabetes. So that is what again it shows that there are differences between various beta blockers also. So beta blockers are not all equal members of one family of drugs. Carvedilol causes vasodilatation, we know, via inhibition of sympathetic alpha receptors, and nebivolol causes NO-derived, nitric oxide-derived vasodilatation. So you have a difference in each and every molecule amongst the class of beta blockers. Now let's look at in various indications where it is used. So beta blockers in the management of hypertension. Now there was a decade where beta blockers were taken a back seat, and now if you see in last 2 years again it has come up again. 2023 for the first time again, now European Society of Hypertension guidelines, they have mentioned that role of beta blockers, and in fact they have given a selected indications where it is must beta blockers. So like chronic coronary artery disease as an anti-ischemic therapy, post myocardial infarction, acute coronary syndrome, HFrEF and HFpEF, atrial fibrillation, arrhythmias, women with childbearing age. So where beta blockers are preferred, and then there is a big list of selected other conditions. So where we know that beta blockers has got a role. So we know it is back over there. Now, beta blockers and the incidence of major cardiovascular events when you compared with the placebo, and what it has shown from this chart that you have got beta blockers as a BP lowering agent resulted in a significant reduction in incidence of major CV events compared to placebo. And this is the all the risk when we have heard over a period of time, which is more common or prevalent in a diabetic population also. Now, comparing the various beta blockers, we know now that bisoprolol is an alternative to metoprolol succinate, which we there because it has a more cardioselectivity. Of course, it is more cardioselective than atenolol. And when you talk about the heart rate control compared to carvedilol, bisoprolol has got a better heart rate control also. So in hypertension management, we know the various societies, be it European Society of Hypertension, be it European Society of Cardiology, and all have been mentioning that beta blockers has come up in a big way. And of course, you are going to use more selective beta-1 receptor blockers and with a more of vasodilating properties, and where bisoprolol scores over the other beta blockers. Talking about beta blockers in angina, again, all the guidelines, including the NICE guidelines, also recommends beta blockers and CCBs for stable angina. Now, there is enough data that beta blockers would score over CCBs in terms of the symptomatic benefit also. So this is the trial, the total ischemic burden bisoprolol study tips, a multicentral trial comparing bisoprolol and nifedipine, and it has shown that bisoprolol was more effective than nifedipine in reducing both the number and duration of ischemic episodes, especially when the people have it in the morning. Now, beta blockers in myocardial infarctions, of course, it goes without saying it is a mandatory thing because it is an improvement of myocardial hypoxia. It enhances the cardiac function and improves myocardial compliance and blood perfusion. So obviously, it is absolutely mandatory on all patients with acute coronary syndrome and myocardial infarction. Now, the data of bisoprolol, early bisoprolol in a setting of non-ST elevation myocardial infarction, what does it show? That it is a reduced incidence of ventricular arrhythmias and cardiac death also. So not only just ST elevation MI, but non-ST elevation MI, it has shown the beneficial effect which is definitely a plus point. Now, talking about atrial fibrillation, we know that there are various drugs which are available, but again, beta blockers have been used in all sorts of arrhythmias. So not just atrial fibrillation, but all sorts of supraventricular arrhythmias, post-surgical setting, non-surgical setting, even in the post-catheter ablations, we have seen the results which are there. And of course, you will be surprised to know that even the bisoprolol has been tried in all these indications with a huge success rate also. Now, we have heard from the previous speakers also. Dr. Rajiv Chawla sir mentioned about the heart failure, and we know that there are 4 pillars. Sir already mentioned about the 4 pillars of heart failure, where beta blockers is of course one of the main pillar, and it is absolutely mandatory to use it over there. And you have used various beta blockers in that. It's stuck over here. Not moving. Yes. The CBIS-2 trial, I'm sure all of you are aware about it, the cardiac insufficiency bisoprolol study 2, where it has shown that beta blocker therapy with bisoprolol had provided survival benefits in a stable heart failure patients compared to obviously other standard modes of therapy. So you have seen that there are various therapies. Of course, there are n number of data is there, but due to the paucity of time, we cannot show over here. Now, this is one trial where bisoprolol has been compared with carvedilol and metoprolol succinate in the treatment of chronic heart failure. This is head-to-head trial, and again it has shown that bisoprolol has slightly better mortality rate compared to carvedilol and metoprolol in CHF patients also. So there's again a beautiful study where it has shown that beta blockers can reduce the mortality in overweight, obese, high-risk hypertensive patients with type 2 diabetes. So there is a 23% reduction in death from any cause in patients receiving a beta blocker. So you know this in a diabetic population, the benefits which are there. Remember, what are the goals of diabetes care as given by ADA 2024 and EASD 23? That prevent complications and optimize quality of life. And here you are to prevent the complications. So what are the guidelines and clinical recommendations for beta blocker use? Starting from uncomplicated hypertension, it can go up to complicated hypertension with arrhythmias, coronary artery disease, patients with increased sympathetic activity, congestive heart failure, or with other comorbidities like CKD, smokers, COPD, diabetes, young hypertensive with LVH, obesity, and resistant hypertension. So various potential cardiac benefits of beta blocker in patients with diabetes: anti-atherogenic, anti-arrhythmic, anti-ischemic, and reversing the cardiac remodeling. So it has in a CV continuum for primary prevention, secondary prevention, and heart failure management. So I would end with the quote from William Osler that the good physician treats the disease, the great physician treats the patient who has the disease. And you are there not to just treat a diabetic patient, you need to look across the continuum. So to summarize, sympathetic overdrive leads to elevated heart rate and development of multiple CV risk factors. Underlying mechanism of hypertension can be different in different population. Beta blockers are good as other classes in younger patients also, can be safely be used at any times hypertension. It helps to prevent sympathetic overdrive. And of course, cardioselective and highly selective beta-1 blockers play an important role in the management of hypertension and diabetes. Thank you for your patient hearing, and would be happy to take up the questions if there are any.
Thank you, sir. Thank you for this lucid presentation, and I hope everybody will be it will be easy for them to choose beta blocker in our diabetic patient management. Thank you, sir. 1 or 2 questions?
So bisoprolol, how to start in and how to titrate it in a early heart failure or hypertensive patient?
Correct. If you are using in patients for hypertension, you can definitely start with 5 milligram. If you are using for a heart failure with hemodynamic compromise, you will start as low as even 1.25 milligram also. But if the hemodynamics permit, you can even start with 2.5. So you have a choice starting right from 1.25 to 5. You never start with 10 milligram at upfront.
in heart failure cases also, we have
The
to use
1.25, yes, which you can start with, but you need to go whatever maximum tolerated dose you can reach, where you will have a maximum benefits by getting on that. Thank
And
you.
definitely it is better than metoprolol in case of COPD and slightly asthmatic.
Yeah,
mild
that is
asthma.
because of higher beta 1 selectivity.
Thank you, sir.
Thank you.
Thank you. Thank you, sir.
Thank you.
So, next speaker is Dr. Yam Shanmugavelu. He is a consultant physician diabetologist from Tamil Nadu. He is a chairman academic RSSDI and past secretary RSSDI Tamil Nadu chapter.
Yes, respected chairperson, senior doctors, my doctor friends, I feel happy to make a presentation on ethical considerations, the management of metabolic condition with a particular focus on evidence-based findings. I thank the chairperson for his nice introduction. So thank Dr. Manoj Chavala for his kind invitations. My disclosures, what I'm going to do for another 13 minutes. The contents of my talk line includes introduction, ethical consideration, achieving optimal glycemic goals, addressing the metabolic dysfunction associated steatotic liver disease, and conclusions. So defining responsibility of a practicing physician is to make decisions on patient care in different settings. These decisions involve more than selecting the appropriate treatment or intervention. Ethics is an inherent and inseparable part of clinical medicine, as a physician has ethical obligation to benefit the patient, to avoid or minimize harm, and to respect the values and preferences of the patient. Ethics is a broad term that covers the study of the nature of morals and the specific moral choices to be made. Four principles that constitute ethics are beneficence, non-maleficence, autonomy, and justice. Beneficence and non-maleficence can be traced back to the time of Hippocrates to help do no harm, while autonomy and justice evolved later. With the passage of time, both autonomy and justice gain acceptance as important principles of ethics. The principles of beneficence, obligation of the physician to act for the benefit of the patient, and supports a number of moral rules to protect, defend the right of others, prevent harm, remove condition that will cause harm. So it calls for not just avoiding harm, to benefit the patient and also to promote their welfare. Non-maleficence, that is the obligation of a physician not to harm the patient. Do not kill, do not cause pain or suffering, do not incapacitate, do not cause offense. That is, the patient should weigh, physician should weigh the benefits against the burden of all interventions and treatment, to eschew those that are inappropriately burdensome, to choose the best course of action for the patients. So ethical principle is that all persons have intrinsic and unconditional worth, should have the power to make rational decisions and moral choices, and should be allowed to exercise his or her capacity for self-determination. So justice, that is interpreted as fair, equitable, and appropriate treatment of persons, and the distributive justice refers to the same healthcare resources determined by justified norms that structure the terms of social cooperation. So the goals of ethics education: one is to appreciate the ethical dimension of patient care, ethical principles of medical profession, ethical behavioral skills like obtaining informed consent, assessing the decision-making capacity, advancing care planning, effective communication, to know the commonly encountered ethical issues in general, to have the competence in analyzing and resolving the ethical problems, to appreciate the cultural diversity and its impact on ethics. So let us move on to ethical considerations. This ICMR in-depth study, conducted from rural as well as urban areas of several states, that assess the metabolic disease prevalence in India, like diabetes, hypertension, dyslipidemia, and obesity. And the prevalence of diabetes and other metabolic NCDs in India is considerably higher than previously estimated. So achieving optimal glycemic goals, the START study conducted to assess the total and complex carbohydrate contents in the daily diet. This cross-sectional study also provided a good opportunity to assess the glycemic control in patients with the type 2 diabetes. So the glycemic control, if you look into data from START study showed nearly 67% of the patients do not achieve their glycemic targets in India. Kindly focus your attention on fasting, post-meal, as well as A1C. Only 33.1% of the diabetic population had A1C less than 7%. So the ethical dilemma in diabetes management, balancing the therapy intensification to achieve glycemic goals, to minimize the diabetes-related risk of complications, and also to avoid over-treatment in terms of the risk of hypoglycemia as well as body weight. So ineffective diabetes management results in suboptimal glycemic control and adverse health-related outcomes attributed to medication non-adherence as well as therapeutic inertia. So the treating physician, they have ethical dilemma between averting the risk from over-treatment and preventing harm from raised blood glucose levels. So the ethical dilemma in diabetes management, balancing the desire for beneficence as well as avoiding harm. So the ethical challenge of balancing desire for beneficence, that is improvement with reference to glycemic control to minimize diabetes-related micro as well as macrovascular complications while avoiding harm, that is inadequate therapy induced hypoglycemic episodes as well as weight gain to patients, is well established. Next is intensive glucose control. Data from DCCT has shown highly effective in reducing the risk of developing microvascular diabetes complications. Next is the 30-year follow-up EDIC study showed 30% risk reduction for any cardiovascular disease endpoints. This Cochrane database of the systematic review showed a greater weight gain and an intensive control as well as the risk of hypoglycemia increase for patients who started with A1C value less than 9. So the clinical inertia. Type 2 diabetes is a progressive disease. Multiple intervention will need to be used while managing diabetes as the duration advances. So the timely treatment of patient with the diabetes has a beneficial effect on outcomes. So the conventional conservative line of approach, the treatment to failure versus the proactive management. So there's a delay in the intensification of treatment in the treatment to failure approach may have a negative impact on the long-term outcomes for patients. On the other hand, the proactive approach, earlier and more aggressive intervention approach, it provides rapid glycemic control, improves patient glycemic profile without significantly increasing the incidence of side effects. So the consequence of delayed intervention, patient with the A1C greater than 7, less than 1 year, and more than 7, the clinical inertia results in prolonged periods of uncontrolled hyperglycemia and increase the risk of diabetes-related complications and reduces the life expectancy. So the causes for clinical inertia and therapeutic inertia are multifactorial, may be related to healthcare system related barriers, patient related as well as physician related barriers. So the clinical inertia is multifactorial. Addressing one factor alone is likely to have limited success. So the deliberate decision, therapeutic inertia in a poorly controlled diabetic may aggravate an early onset of diabetic complication, endangering the physician's ethical compliance with the non-maleficence principles. Next is medication adherence across all conditions. More frequent dosing was associated with a lower compliance rate, and simpler, less frequent dosing resulted in better compliance. So if you look into the poor adherence with reference to all-cause mortality, increases the risk of all-cause mortality due to poor adherence by 39%. So patient may have poor glycemic control related to medication non-adherence, and the assessment of non-adherence should be incorporated into routine clinical practice. CGM is great, but should every patient with the diabetes have a CGM? However, the accessibility and utility depends on 3 questions. Will my patient be able to afford it? Is my patient willing to bear it? Is my office ready to take full advantage? Right. So identifying the right person for CGM. Insulin-treated individuals, pregnant women, type 2 on intensive therapy, and poorly managed diabetics from understanding the influence of diet, activity, and medications. Next is with reference to ethical consideration in the treatment of childhood obesity. We have 3 pillars: family-based therapy, pharmacotherapy, and bariatric surgery. And the pharmacological agents to treat obesity in patients. That is, we have the orlistat, liraglutide, and semaglutide. So lifestyle, diet, and exercise should all be implemented in conjunction with the medication, and families are encouraged to be involved. Better increase the chances of sustainable weight loss in obese adolescents. And next is A1C goals must be individualized, less than 7, less stringent, less than 7.5, or A1C goals less than 8%. Next is bariatric surgery versus intensive medical therapy. 5-year outcome data showed patients with type 2 and a body mass index of 27 to 43, bariatric surgery plus intensive therapy was more effective. ADA 2024 consider metabolic surgery as a weight and glycemic management approach in patients with the diabetes with a body mass index more than 30. So treating older adults, optimal glycemic target, still a debate. ADA consensus statement, AACA guidelines as well as our own RSSD clinical practice recommendations. So is it stringent A1C target always? In older diabetic patients, frailty or at risk of hypo, a target of more than 20% TIR with less than 1% TBR is now recommended. Addressing MASLD, so renaming, so steatotic liver disease, more than 5% fat in the liver, cardiometabolic risk factors. That is diagnosing a condition for which there is no effective treatment. Potential harms of diagnosing the disease in health. Considering the liver biopsy, when there is a definite evidence of MASLD, is liver biopsy justified for diagnosis? Biopsies taken for research and clinical trials raise ethical questions. The general consensus is that it is reserved in cases where with uncertain diagnosis or to confirm advanced liver fibrosis. Next is lifestyle modification, gold standard, remain first choice in the management of obesity and obesity-related comorbidities. Weight loss of greater than 5 to 10% that is associated with improvement in liver function and histological features of NASH. Next is FDA approves resmetirom, 80 milligram, 100 milligram, but superior to placebo. But what could be the cost? Availability, 90,000 rupees. That is one box, one bottle contains. Next is we need a molecule that should address diabetic dyslipidemia, diabetes mellitus, as well as NAFLD and NASH. So bariatric surgery resolved NASH in liver biopsies from 84% of patients 6 years later. The reduction of fibrosis began during the first year and continued through 5 years. Is bariatric surgery for obesity in children justified? Bariatric surgery performed on children with obesity highlights the moral dilemma even more clearly. 120% of the 95th percentile or 150% of the 95th percentile or BMI more than 35 kg with type 2 diabetes, obstructive sleep apnea or patient present with non-alcoholic fatty liver disease. Next is summarizing the ethical issues and challenges associated with non-alcoholic fatty liver disease and potential solutions with reference to ethical issues, challenges, and potential. So application of principles of ethics in patient care. We give the clinical assessment, nature of illness, goals of treatment, treatment options, and probability of success. Next is patient rights and preferences, information given to patient on benefits and the risk of treatment, and patient mentality competent. If competent, what are his or her preferences? Next is quality of life, expected quality of life with and without treatment, deficit, judging the quality of life. Next is external forces and context, conflicts of interest, and research or educational considerations. So the integrated model of patient care. So the medical knowledge, skills to apply that knowledge, technical skills, practice-based learnings, and communication skills are partnered with ethical principles and professional virtues. The virtues of compassion, discernment, trustworthiness, integrity, and conscientiousness are the necessary building blocks for the virtue of caring. So the physician's obligation, cure of the disease, maintenance or improvement, promotion of health and prevention of disease, prevention of untimely death, education and counseling of patient, avoidance of harm, providing relief and support. Conclusion. In all interaction with the patients, besides the technical expertise of a physician, the human element of caring is needed. Gentle touch, especially when conveying bad news, firmer touch or grip to convey reassurance to patients facing a difficult treatment choice, hold the hand of a patient dying alone. So the secret of the care of the patient is caring for the patient. So before I conclude, I invite our delegates to register for this conference, Tamil Nadu chapter RSSD annual conference, going to be held on 28th and 29th September in Chennai. And next is RSSD annual conference, Delhi, between 14th to 17th November. And we have the 4th RSSD research retreat that is going to be conducted in Madurai, Tamil Nadu on 1st and 2nd March. Please attend and make this, all the three, a memorable and a successful event. Thank you very much.
Thank you, sir. Thank you for this lucid presentation. Definitely, diabetes is a management, and management always consists of overall things. So ethics plays very important role in diabetes management. We have to think as a whole, not as only a disease, or not as just treatment part. Thank you, sir.
Thank you so much. Thanks a lot.
So next we have Dr. S.V. Kulkarni. He's a senior physician from Mumbai. And as you all know, he is like technology guy and he is famous in medical fraternity as a technology guy only. So over to you, sir. Thank you.
Thank you. Thank you, organizers. Can I have the slides, please? It's a very unusual topic, a bit out of the way, but that is, on the smartphone is something which is common between all of us. Everybody of us is having not only one smartphone, but two smartphones and 4 or 5 SIM cards, different for different persons. Okay. So I appreciated the mission and vision of Manoj and Purvi and all the group. It's something absolutely fantastic and proud to be part of the project. For me, it is a family affair. Ketan was 2005 API organizing secretary, Narayan and others who are going to be the future RSSDI and API presidents. I'm just a part of everything and really excited. This is me in brief, and actually it is my battle with technology against all the physicians. Manoj, you recall in API when we used to take a workshop, public used to call me only one thing, that he is crazy, and some other different Hindi or Marathi words. Okay, but I think the things are really true. Why we are talking about the apps? It is said that there is an app for everything in this world. And what are apps? They are the miniature programs. They occupy less space on your RAM. They have got fantastic speed, and yet they mention the functionality. They are easy to share, sometimes in a text form, simple uploading, upgradation, uninstallation. There are many free apps. Don't buy for that. They are infested with advertisements. But always buy a paid version. There is nothing like a free lunch in this world. Don't buy the most advanced one. Buy the just beginning stage. Then where is the money? Money is in your smartphone. Money is in your patience. Look the way in which what is predicted. Huge up, almost 15 to 20 times. There is no other investment which is going to give this amount of CAGR in the field of medicine. And this was the picture last year when there were a lot of apps which are come. Now I'm going to do something very simple. Do you know what is the EGFR of applications? The EGFR stands for evaluation parameters, downloads. How many people have downloaded the app, reflecting the popularity? What is the Google rating? This is on Google Play. There is something called as the Play Protect. What do you do in Play Protect? It tells you that whether this application is safe or not. What are the features? And most important, don't forget the R. What is the real life experience and what is the utility? So what are the types of app where we can use 4 groups? Patient care and monitoring, health apps for the lay persons. There are apps for communication, research and educational purpose. And most important, physician and student reference app. So let us go one by one. This is my favorite and it should be part of your smartphone. Please don't take any pictures because I'm going to share this presentation with you. If you try to concentrate on this, it will help you. Improves clinical decision making. There are hundreds of tools governing the specialties. It uses the latest medical evidence and it determines more accurate diagnosis. And imagine 3 million people are using it, 3 million. There are certain apps which are single point apps. BMI calculator, HbA1c converter from millimoles to the conventional values. But QXMD has everything. Now, please download this, not for yourself. Do it for your staff. I'm very happy that my colleague, Dr. Rahul is here. And my staff also knows how to calculate BMI from QXMD. They know how to calculate the ASCVD score and your time is reduced. Muse, majority of us here are primary care physicians and we must train our staff to understand what are modified early warning signs. There is nothing like a sudden cardiac death in this world. There is nothing like uncontrolled diabetes in the world. There are certain signs which you tells and how to identify it. This is one of the best way to. The second one, big boy, Medscape. It has got everything. references, interaction checker, very important, medical news, medical education, directory. You can prepare your own directory of your place. How many people are gastroenterologists, how many are cardiac surgeons. It tests your knowledges. And most important, it gives you access what you need and when you need it. That is most important. And these are the different screenshots. You can get news, you can get references, education. But I will ask everybody of you to concentrate on the drug interaction checker. Please check drug interaction checker and remember this Q, two alphabets, QTC. You must have lost till today not 10, 100 of patients in your hospital of sudden cardiac death. They are all because of the combination of the drugs which increase the QTC. Azithromycin, darifylline, domperidone, pantoprazole, beta blockers. If given in combination, they go on increasing the QTC interval and you find the patient dead in the bed. My third player and fourth player are combinations. Which are they? Dynamed Plus and Up to Date. Definitely they are a bit costly. But in this world, there is always some cost which you have to pay for quality. It is said that there is nothing like peanuts in this world. These are the important clinical decision support tools. How I look at this? Content and coverage. All the C. Who has created it? What are the contents coverage? What is the user interface and accessibility? Very important. User friendliness is very important. What are the strengths and weaknesses? How many times it has been corrected? How many times it has been criticized? I don't want the goody language that Suhas Erande, your app is very good. I am very happy. Jaipur app is very good. No, correct it. Find the flaws and correct it. Pricing and subscription. Pay something. Everybody has to run his family. This is a fantastic YouTube video. I will share you the link. So they are not fighters to each other. They are complementary apps. And how? It depends upon your work setting. What is your kind of setting? Dynamed Plus, which is a part of American College of Physicians, it is ideal for clinicians who need quick, concise and actionable information at the point of care with a focus on latest evidence and guidelines. And up to date is no doubt it is fantastic one, but up to date there is a lot of overlap. Suppose if you just take one topic of GBS and how it is going to approach and how it is going to treat it, it is better suited for those require comprehensive detailed information and willing to spend some more time navigating the context. It is also preferred in academic settings and by specialists needing depth analysis and discussion. So friends, don't worry. रोज का 100 rupees guru dakshana up to date ko dene ka. That guru will never fail you in life. 100 rupees per day, some 37,000 rupees. Go for this. Dynamed Plus, very easy to become member of American College of Physicians. The access is free. There is something out of the way which I talked. So we talked about apps on one side, conventional apps. Is there anything which is powered with AI? Because Ketan is smiling in his face, say that how he has not come out with AI. And sir, last meeting I will tell you, I was in ACP. Somebody introduced me as not SV Kulkarni, but AI Kulkarni. That was something really funny thing about it. So this is an app called as a Medic. Now please download it. Why to download it? It is a personal app. It is an AI-driven health assistant which has got accurate medical insights. It leverages extensive medical data. This is an unparalleled accuracy in analyzing complex medical reports and finding detailed analysis information. Suppose if you want to know synovial fluid comparison parameters in comparison with the serum, if I got a synovial fluid protein of 5.8 and if I got a simultaneously blood serum protein as 5.2, what is the implication? It has got a built-in medical dictionary. You will never be left in the dark about the different kind of medical jargons which you have. We get a lot of patients of COPD, asthma, even diabetes has got a lot of distress. And we tell them to do some simple exercises. So this is a very simple app called as a Better Breathe. It is only in disease as well as wellness. Actually, I would have talked about 101 good apps in clinical medicine, but I have to cone down only on Satya Pe Satta. That is, Better Breathe is spreading awareness about the effect of guided breathing. It harnesses the transformative power of breath, and there are curated selection of breathing exercise which the patient can do. Means you can put on your earphone, the phone is in front of you, and you can follow the instructions. It will make a lot of difference. All the hypertensives, diabetic distress patients. Last, breathing, yoga, everything is over. Exercise, most important, which we disregard. Open your Google, there is an app called as a Fit. And aim from, not from tomorrow, today, that I am going to walk 10,000 steps. I'll tell you, your HbA1c will never touch cross 6. But only thing they do it religiously. Every mobile has Google Fit, tells about the time duration, step counts, map, kidhar ghumaya, approximate calorie consumption, encourages messages, positive messages. It can talk with digital watch. After all, what is technology? Technology is man to machine talk, and machine to man talk. Suppose if you are in a habit of walking early in the morning, you will get an alarm that it is a time to walk. There is an app called as the Calorie Mama. This is a westernized mama. So I request all the organizations in India to come forward to have a South Indian mama, Punjabi mama and Maharashtrian mama, so that you snap the food and you will come to know what are the calorie counts. Snap and eat with signal color codes. So friends, I'm just now going in a very fast way because only 4 minutes are left. Don't forget, this mobile phone is a big weapon. There are so many things which we don't know. It can detect a fall in an elderly person. The face of mobile phone is going to change like this. You will be wearing like a ring, or you can be there in your spectacle. You will not have anything in your body, but you can do all the functions of it. It will be on your hand. These are the medical equipments which are going to be replaced. They are going to be part of your mobile connected attachment. Don't believe a cricket team of it. Thermometer, pulse oximeter. Now I have got a pulse oximeter which detects even the respiratory rate. And perfusion index, most important, those who are managing malaria, typhoid, dengue. If perfusion index goes low, then the person is at risk. A stethoscope, ophthalmoscope, otoscope, portable ECG. Ketan has got an article and research on this. A microscope, glucometer, dermatoscope, very easy. Just take a picture and find out. This is banned in India. Only at ICU you can do a focus. There are a lot many good and new things. There is a video laryngoscope, a boon for patients where at the time of crisis, anesthetist, intubation, the blood pressure measurements, no tube, no bulb, no cough, only cough and the reading on your smartphone. Spirometer predicts the episode of impending exacerbation of COPD. There can be a brain scanner, a spectrometer, a concept. Don't forget this word, lab on a chip. Put a drop of blood. Within 15 seconds, you get a QR code, scan it, you get antiproben. And I'm not talking science fiction. These are all going to come in the near future. Calorimetric smartphone capnography for obstructive sleep apnea. We will be having docs like this, a thermodoc, glucodoc and cardiodoc. And there will be multiple combinations of phones like this. The phone interior structure is really very friendly for all of us and we can modify. The branch next to clinical medicine is anesthesia. They also do have a lot of good apps, and the future of medical app phones will be like modular phones. These are the things which will go on extending your things. The future sensors are called as the microelectronic medical systems, MEMS sensors. They will be really fantastic. Don't forget, AI is going to be helpful for the healthcare apps. You will be having a smart bot. Your mobile will be converted into a smart bot. Somebody calls, doctor, are you available on Monday morning? Yes. The bot answers that between 10 to 12:30, you can take an appointment. So friends, we are cribbers. I want to do, I can't do it. I want to do it. How I do it? I will try to do it. Then Narayan comes and he tells, yes, you can do it. And then you have to confirm, I will do it. And yes, I did it. So friends, do the same thing with smartphone, apps, technology and AI. You become vigilant, smart, quick, multitasking and ever demanding. Finally, doctors save the life of patient, but smartphone will save the lives of patient as well as doctor, including huge amount of time. I cannot forget my batch of 1974, my family, my teachers, and remember these words: stay hungry, stay foolish, and at the same time stay idiot. If you stay idiot, you don't get Alzheimer. Okay, if you want to remain sharp at the age of 70, try to adopt learning technology. So be ignorant, ready to learn, idiotic to pretend, learn from the next generation. Grandchildren are the best teachers, good return on investment. This is a proven vaccine and treatment of fitness and preventive dementia. This is my email ID, or you can contact me for this presentation. The safest place of earth, those who are grandfathers here, they will confirm. A grandson sitting on your shoulder is the best guide for you. Don't forget, there is a lot of research which we can do in Indian setting. This is me and my assistant, Dr. Sagar Sinha, first book of the kind in the world, digital technology in clinical medicine. There are a huge number of journals. There is one journal called as NEJM AI, spend 15,000 rupees every year. So friends, be optimistic, informed, empowered, futuristic, build a bridge of knowledge, clinical acumen, experience, AI and technology. Thank you very much. If you are not traveled on this bridge of Atal Setu, do it today afternoon. Thank you very much for the time.
Thank you, sir, for a kind, very lucid presentation. Any comments? If anybody wants to make, who is interested in technology, or we can just go ahead with the next speaker.
I can share you this presentation, and if you want any presentation on any subject, you give me order 10 o'clock at 10 p.m., 6 a.m., it will be delivered to you. Anything in this world.
Thank you.
Yes.
Thank you, sir.
Right from whether a ghost exists or whether there is a supranational power, I can prepare a presentation. Thank you.
Thank you, sir. So next we have Dr. Narayan Devgavkar. He has got almost more than 30 years of clinical practice in diabetology. This August gathering knows him well, and he is a regular speaker for all these national and international conferences. So he's going to talk regarding the LADA. Over to you, sir.
Yes, good afternoon. After wonderful talk by S.V. Kulkarni, very dynamic speaker, very intelligent one, and the man of computers, I can say, and technology. He's a fantastic friend of mine. Actually, I must thank Manoj, Purvi for giving me this opportunity to talk on this important subject, rather, it is which is neglected one. So actually, this is a topic which has been neglected so many times. How many of you diagnose the patients of LADA? Actually, we think very rarely. So many times when the patient of type 2 diabetes comes to your clinic and his age is in between 30-35 years, we have to give a thought that this patient may have LADA, because considering his build, considering his other metabolic syndrome parameters like hyperlipidemia, hypertension, all if they are not there and still patient is diabetic, so I think you must give a thought on this LADA as such. And in UK, in London, there was a study which has been published, and it is said that almost 10 to 15% of the patients of type 2 diabetes were diagnosed to have a LADA. So it is mainly in patients of young onset diabetes. Diabetes is basically a specialty. Either it can be a type 1 diabetes or LADA, because type 1 diabetes and LADA, age of the type 1 diabetes is a little bit less, it is less than 30 years, and when the patient has got a diabetes and there is autoimmunity, we think of labeling them as a LADA. Then in patients who are early onset type 2 diabetes in children, that also we have to give thought on the LADA, and you have to do antibodies. And third important criteria is MODI, maturity onset diabetes of young. So LADA is a latent autoimmune diabetes in adults, is a form of autoimmune disorder which is diagnosed in individuals who are older than the usual age of onset of type 1 diabetes. And the alternative terms used is, as all of us know, is whether it is a type 1.5 diabetes, which is very commonly used nowadays. And often patients with LADA are mistakenly thought to have patients of type 2 diabetes. So what is the pathophysiology? The LADA patients share genetic features with both type 1 and type 2 diabetes. Antibody positivity and clustering is very commonly seen in LADA. Because it is in between type 1 and type 2 diabetes, it is called as type 1.5 diabetes. So what are the diagnostic features and what are how you can label these patients are having a LADA? LADA positive for autoantibodies and C-peptide levels, which we are not doing very commonly. But if we do it in this type of patient, we find that C-peptide levels are low in patients of LADA. On the contrary, if the patient has got type 1 diabetes, there are no C-peptide levels, almost very low. And type 2 diabetes, we see normal C-peptide levels. What are the broad characteristics of these patients? Age of the onset, which already I have said, is more than 30 years. There is a family or personal history of autoimmunity in these patients. There is a reduced frequency of metabolic syndrome, which is very commonly seen in type 2 diabetes, like patient having these patients are having lower BMI. On the contrary, patients of type 2 diabetes are obese and they have got a more BMI. They low blood pressure. Then their normal HDL levels and even LDL levels are also normal in these patients, which are more in patients of type 2 diabetes. There are no disease-specific difference in cardiovascular outcomes, whether patient is having LADA or whether patient is having type 1 diabetes or type 2 diabetes. C-peptide levels decrease more slowly than type 1 diabetes. So patients having type 1 diabetes already has got a C-peptide levels very low, but the decrease in C-peptide levels in patients of LADA is lowered very slowly. These patients very specifically are positive for GAD antibodies, and they are they don't require insulin initially. These patients can be managed on oral anti-diabetic drugs, particularly metformin, and other non-sulfonylureas drugs. What is the key difference between type 1 diabetes and LADA is not the age of the person when they are diagnosed, but the gradual way the disease progresses. So this you can see in these patients, the age of onset is more than 35 years. Metabolic characteristics of LADA are insulin-resistant metabolic syndrome. LADA resembles type 2 diabetes clinically. Insulin resistance also has been reported in LADA patients like type 2 diabetes. However, studies suggest that the metabolic features in LADA are more similar to type 1 diabetes than type 2 diabetes. So these are the C-peptide levels which we see in patients of LADA. So here you can see that subjects with LADA has a clinical characterized similar to with adult onset type 2 diabetes with rapid progression of the disease. C-peptide levels did not differ at onset, but they decrease rapidly in patients of LADA afterwards. Age of onset, which already I have said, it is between 30 to 35 years. Presenting as a non-obese type 2 diabetes. So as already I have said, in patients who are type 2 diabetes, if they are a young one, you must give a thought on these patients whether they are having a LADA, and you must do autoantibodies in these patients. Initially, these patients are controlled only diet and exercise and oral anti-diabetics, not sulfonylureas. You can give other oral anti-diabetic drugs. There is early failure of oral agents, particularly then these patients require some or other time insulin in their future, and insulin dependency within months or years of diagnosis. The other features are ketosis may or may not be present in this, which is very common in type 1 diabetes. The low fasting and simulated C-peptide levels, no clear-cut diagnostic criteria. Anti-GAD antibody positivity is very common in this. That is the diagnostic of LADA. Anti-ICA antibody positivity, HLA susceptibility alleles is also seen. So when to suspect these patients of LADA? If the age is more than 30 years, symptoms are acute one, BMI of these patients is less than 25, then personal history of autoimmune disorders is common, and family history of autoimmune diseases. The age already I said is, then algorithm or LADA diagnostic pathway based on anti-antibody screening and C-peptide levels at the diagnosis. GAD screening, if it is positive, measure serum plasma C-peptide levels. If it is less than 0.3 nanomillimoles per liter, you have to apply LADA algorithm, which I am going to discuss afterwards. Then if the C-peptide levels are in between 0.3 and in between 0.3 to 0.7, even also that time also you have to give a thought on LADA. Even if but if it is less than 0.3, it is a clear-cut case of LADA. If it is more than 0.7 nanomillimoles per liter, you have to think that this patient is having a type 2 diabetes, and depending on the complications, you have to apply ADA or ESD guidelines. If the GAD antibodies are negative, then you have to first think of type 2 diabetes. And if suspect if the patient is lean, and do a screening for 1A and 2A. And repeat C-peptide levels after 6-month intervals for deterioration of glucose controls. So what are the autoimmune disorders which are common with LADAR? One is hypothyroidism, another is celiac diseases, Addison's disease, rheumatoid arthritis, pernicious anemia, and vitiligo. The fasting C-peptide levels is very helpful to identify the LADA in type 2 diabetes patients, especially in Indian population. Protocol for confirmation of LADA is antibody testing, which already I have said is anti-GAD 65 antibodies, anti-ICA, and anti-1A2. GAD testing will be more cost effective, and it is preceded by another screening test. How you are going to manage the patients of LADA? LADA patients do not require insulin for the first 3 to 6 months following the diagnosis, but they may be controlled with oral anti-diabetic drugs, particularly metformin and other drugs other than sulfonylurea. But up to 80% will require insulin within next 5 years. Most patients are treated according to the standard management protocol for the type 2 diabetes. And due to the destruction of the beta cell, they become insulin dependent more rapidly than the classic type 2 diabetes patients. This is the study which has been published, and early insulin treatment in LADA leads to better preservation of metabolic control and was safe. And superior preservation of C-peptide could not be significantly demonstrated in this particular study. So immunopathogenesis, I will not go into the detail of that. So how you are going to manage it if glycemic control is at a goal on oral agents, continue them. Watch closely for worsening of control on oral agents. If 2 agents are failing, then add in this patient insulin or may continue metformin. Metformin is the drug of choice in this patient. Usually need to go to the basal insulin or basal bolus insulin. And if ketones are persistently positive, as we already know, you have to start on insulin. Recognition is important, so insulin treatment is not delayed as A1C climbs more. This is the algorithm for glucose lowering medications depending on the C-peptide levels. If it is less than 0.3 nanomillimoles per liter, or with C-peptide more than 0.3 to 0.7. If it is less than 0.3, start immediately with the insulin. If the C-peptide levels is in between 0.3 to 0.7 nanomillimoles per liter, use metformin and reassess every 6 months. No sulfonylureas. We have no sulfonylureas because sulfonylureas may cause destruction of beta cells and patient may require insulin early. So it is better to start these patients on metformin only. Indicators in high risk established atherosclerotic cardiovascular disease or the patient having CKD, which is common in diabetic patient. If the ACVD predominates, GLP-1 receptor agonists, then SGLT2 inhibitors or insulin may be required in this patient. And if the HbA1c still goes above the target, these patients require insulin. If the patient has got CKD as a prominent disorder, you have to add SGLT2 inhibitors. And still if the HbA1c deteriorates, treat the patient according to the ADA or ESD guidelines. The glucose lowering medication in LADA, C-peptide levels more than 0.3 and without established atherosclerotic or cardiovascular disease or CKD. We can add these patients, treat these patients with DP4 inhibitors, GLP-1 receptor agonists, SGLT2 inhibitors, and glitazones. Depending on the control, ultimately, finally, these patients may need, if they are not well controlled, as a insulin as the treatment of choice. Then this is the algorithm, C-peptide levels. If it is less than 0.3 nanomillimoles per liter, start insulin. If it is in between 0.3 to 0.7, start metformin, no sulfonylureas. And if it is more than 0.7, you have to treat these patients according to the ADA or ESD guidelines and reassess these patients every 6 months. This is the indication of high risk established patients, as already I have discussed in detail. If the ASCVD predominates and then heart failure or CKD prominates, depending on the conditions, you have to treat either with SGLT inhibitors or GLP-1 receptor agonist, and you may require insulin in later stage. So these are the how you are different type of features. Age of the diagnosis. This is in type 1 diabetes, type 2 diabetes in LADA. Age at diagnosis. Usually type 1 diabetes, as already said, it is childhood onset. If LADA is in between 30 to 35 years,
and adult onset diabetes is a type 2 diabetes, maturity adult onset diabetes. Family history, which is uncommon in type 1 diabetes. LADA also it is uncommon, but in type 2 diabetes, as we know that there is a family history of strong family history of diabetes is there, either mother or father. Type 1 diabetes, family history, and then ketoacidosis, which is very common in type 1 diabetes. Usually it is absent in LADA, but it is very, very rare in type 2 diabetes. Islet cell autoantibodies, that is GAD antibodies are positive in this autoantibodies are positive in type 1 diabetes. They are also positive in LADA. They are negative in type 2 diabetes. C-peptide levels at our diagnosis levels, they are undetectable or almost they are nil in patients who are type 1 diabetes. In LADA, they are very low or they are low, but they are normally in type 2 diabetes. Response to OHS is absent in type 1 diabetes because that is insulin dependent diabetes. And LADA, initially you can start on oral drugs. They may require insulin afterwards. And then blood response for longer duration is seen type 2 diabetes. And treatment with insulin required at the diagnosis itself in type 1 diabetes. On the contrary, in LADA, you may require insulin after 3 to 6 months. But in type 2 diabetes, you have to manage as per the ED and ESD guidelines. Tendency to develop, as we know that it is very common, ketoacidosis is in type 1 diabetes. Then it is in LADA, and type 2 diabetes is very rare. What are the similarities in type 1 diabetes and LADA? Insulin requirement, low C-peptide, lack of obesity, no metabolic syndrome, insulinitis, anti-GAD and ICA positive, similar to HLA associated endocrinology. What are the differences? As age is already I have discussed, insulin resistance, subnormal insulin secretion, and IA2 antibodies. What are the similarities between type 1 diabetes and LADA? Age, insulin resistance, and initial response to OHH. What are the differences? There is no family history. Phenotype, low C-peptide level, need for insulin, autoantibodies are positive in LADA. Insulitis it can be seen. High rates of retinopathy which are also seen. And long-term effects are related with hyperglycemia. Then what is the difference between LADA and MODI? It's age, phenotype, initially response to OHS, differences, absence of family history, need for insulin, and genetic defects. LADA is a form, in summary, LADA is a form of diabetes mellitus with features standard to both type 1 and type 2 diabetes. Early diagnosis is of paramount importance. Initiating appropriate treatment to prevent the complication is important. And clinicians should consider screening for LADA in patients with type 2 diabetes, particularly when the patient develops at the younger age and the patient don't have any signs of metabolic syndrome. This is particularly true if they are not obese and lack of the features of metabolic syndrome. New insights into LADA's pathophysiology explain beta cell destruction as a slow progression. A C-peptide test basal or after mixed meal may be used as an initial or cost-effective treatment. The LADA is identified which patients need confirmatory testing by islet cell autoantibodies. Insulin and DP4 inhibitors alone and combined with insulin or glitazones or GLP-1 receptor agonists have shown a promising results. Thank you. Thank you very much.
Thank you. Thank you, sir. Nice presentation, and you have simplified the LADA very much. So in the interest of time, we are running late, around 15 minutes, so we are just closing the session.
Thank you. Thank you.
As we conclude our insightful session on various special situations in clinical practices, we now turn our attention to our next topic, clinical diabetology. Please join me in welcoming our chairperson to lead this discussion, Dr. Manish Sachdev, Dr. Deepak Patel, and Dr. Sandeep Mulay.
Good morning, all. After a wonderful session on technologies in diabetes, now we move forward to the clinical sciences again. I welcome Dr. K.N. Manohar, who is a triple FRCP Fellow, American College of Physicians, and that is there, and many accolades to his name. I welcome him to speak on that, clinical diabetology.
I think I'm audible. So precision care in type 2 diabetes, I thought they said about the technology is over and looking into clinical medicine, but I think this topic is a bridge between technology and the clinical medicine both together. So let's see how we tailor our treatment for optimal outcomes. One size doesn't fit all is what we know. What do we do? Move the slide. So, disclaimer, it's not a sponsored talk, and I would like to thank the couple for inviting me here, having a wonderful conference and a session. And we all enjoyed yesterday's gala party, and then we'll see what is happening now. So, precision care, what exactly is precision care? Most medical treatments have been designed with an average patient in mind. So, we may be different from each other. We all have seen that in clinical practice, one medicine may work wonderfully well with someone, but it may not do the same with others. And as we are all unique, precision health takes account of differences in people's genetics, environment, and also the lifestyle. This will help us to optimize the diagnosis, prediction, prevention, or treatment of diabetes by integrating multidimensional data, big data, what we call it as now, and this accounts for individual differences and uses technology for better outcomes. So if we can predict this drug helps you better than the drug B, then we could usually use that. And genetic monitoring can also tell how much is the risk of having a set complications in the future, and we can choose. Now even AD algorithm says if hypoglycemia is a risk, choose these drugs. ACVD is a risk, choose these drugs. So that is where they are getting to precision medicine even by the guidelines. So are there any examples of precision diabetes care? Yes, the best example for precision care in diabetes is at monogenic diabetes. So if you genetic mapping can detect your monogenetic diabetic, then the treatment approaches and outcomes could be totally different, because many times, as the previous speaker was alluding, like the LADA, many times the monogenic diabetics are missed. And we all know the types of MODI. Some are sulfonylurea responders, some don't respond. So even that prediction can be done by genetic analysis, and the precision care pays path for it. And yesterday there was a debate about pre-diabetes. This is what I was mentioning. So pre-diabetes may not be cost effective in everyone is what the precision care medicine says. And we can pick and choose the people in whom it is more effective. Like people with IGT are more amenable than IFG. And people with one additional risk factor apart from diabetes have a higher propensity to regress as compared to everyone else whom we use it. And we have shown even in precision care with respect to pre-diabetes, yesterday's debate same again pointing to the lifestyle interventions are better and sustainable as even compared to the many medications what we use in that. So these are all the learning from precision medicine what we have. So it was a consensus and it was established at 2018-19. It is a phase-wise pathway was laid by EASD and ADA for precision care, and they want to develop guidelines and translate this into clinical practice. So we are on the pathway of it. Soon, like the AD algorithms, we may get into a time where genetic mapping and lifestyle precision can take forward, and we know what intervention suits our patients best. It's not one size fits all for everyone. So what does it in short say? Right patient, right treatment, and at the right time. So precision treatment encompasses all of this. Studies focusing on treatment heterogeneity. We have seen some people respond beautifully to SGLT2 inhibitor, some people don't respond, some people lose weight but they don't get glycemic control, and vice versa also. So why is this difference happening? The answer lies in precision care.
discovery and synthesis of biological drivers, addressing social determinants of health, and of course, learning health systems. These are the 4 important ingredients of precision care on going forward. So what are the pros and cons? Benefit will be definitely improved treatment efficacy. We don't have to do a trial and error. Some people don't respond to certain medications, so we don't have to waste time on that. And reduce adverse effects. Even predicting what drug could cause what adverse effect in what percentage of person and how is it different in the patient sitting in front of you can be mapped. And definitely it helps in better patient outcomes. But the challenges are definitely there. Data integration, cost, accessibility, and need for continuous research. We are still in the early stages of it. So I will restrict my talk because precision care can encompass everything from genetics to prediction to prevention to treatment and diagnostics. So we will look at lifestyle interventions in which I have done some work. And lifestyle is not just what we eat and what we do exercise. It is about sleep, stress, behavioral changes, and also the environment in which we live. Staying in a metro city itself is a high risk factor for ASCVD. As we all found out on our travel for me from Bangalore to airport and then from airport to here in Mumbai. So lifestyle prescriptions, generally, even I used to do this. What do? Diet and exercise is what we say. Definitely there are very, very few takers of lifestyle as the sole prescription. So whenever a patient comes to me with 7.5 or 8 A1C, I usually avoid giving medicines. The moment we write medicines, the emphasis on lifestyle comes down dramatically. So call them early, but try and avoid in case it could be avoidable. So we used to write like this, diet and exercise, but does it suit all? This diet and exercise prescription is as good as this prescription, what you would have seen on our WhatsApp forward, antibiotic and painkiller. So what should we do? I always tell people to meet our life coaches and understand where the patient stands with respect to diet and exercise and work on it. We have moved from 6 meals a day to intermittent fasting and so on. So every exercise, nobody can do a walk or if he is having osteoarthritis, age, so many factors has to be considered and slowly improve the way we transform this lifestyle into that. So I am euglycemic just for the sake of how things can change. We all think millets are the best. I am euglycemic and even now I am having the CGMS. Sometimes I just keep putting it to study myself. So twice I had something on the same day. Second time I had it just to see that if it is really right. And look at my sugar which went up so much. So what do you think I had? Yeah, I had ragi. South Indian, ragi mudde or ragi ball is a staple diet for us in South. So I had that. We traditionally say ragi is best, rice is worst, wheat is moderate. Is it right? Is the question. And whether you have the ragi in the form of a roti or the ball or the porridge, does it make a difference? Whether you have ragi late, if you see me, I had it at 9:30 in the dinner time, which is late dinner. Is it the same as having it at lunchtime? We saw the difference in the glycemic expression also when I had it at lunch and also had it at dinner. So, and we also talk about sugar, jaggery, honey, and fruits versus juices. Most of it we know, but this is the differentiating points what we need to say. So patients started telling me, what sir, you are telling ragi also is not good. Ragi is good, but how much you have, when you have, how you have makes a difference. So I always tell them, okay, you have a ragi ball, you make it into roti and let's see how many rotis comes out of it. A big ragi ball can have 5 to 6 rotis made out of it. And ragi slips in down as a ball without our knowledge. Roti takes time, you chew and you have some substance. So there's a huge difference and nobody can eat 5, 6 rotis, but one ragi ball they swallow even before they realize they are full. So ragi is good, not mainly because of the nutritive value of calcium and iron, it is good, but not so much with the calorie and the carb content is almost the same or slightly better. Same thing with sugar, honey and jaggery. All our fuels, petrol, kerosene, diesel, all are same it is. So only where we talk good about honey is vitamins and minerals, what it has in extra. So these are the things what we need to emphasize to our patient. Otherwise we say 2 rotis to 1 ragi ball is not going to help us in any way. And exercise is very, very important. I have special interest in that. And always we doing exercise showing my medals, that was the showing off or showing the medals in my chamber. It was actually a suggestion by a patient, why don't you put your medals? And everyone sees and they get inspired by looking at us. And when we walk around or do the run in our neighborhood also is a big, I have stories to tell that it may be some other time because we have only 5 minutes left. So again, if you look at the meta-analysis of all the data, if you just say exercise, it has never benefited much. Only a structured advice is only going to benefit. So, and also the mixture. We all know about the WHO guidelines. You should have resistance training, flexibility also incorporated in our exercise regimen, not just say exercise. Even yoga, meditation, flexibility, and strength training should be a part of your exercise curriculum. 5 days a week at least, with not more than 2 days gap. Even the American College of Sports Medicine, what do they say? You need to prescribe exercise the way you prescribe the drugs. If you're telling Voglibos after the first morsel of food, and so much description we give it, similarly, we need to give the description about the exercise and show them and assess them. Each person is different. That's how all these things can't be done by you sitting alone. So you need the help of a team which can focus on this. And I think the previous speaker, Dr. Kulkarni, showed us the digital health is the way forward. We have everything smart, including the water bottle, which tells us when to drink, you are due to drink your water. You are due to get up and move. I don't know whether we all moved after sitting here. If you want, you can just get up and sit at least. Or you can also do the soleus push-up sitting here. So that is one thing which you can do. So what I did is, this is the study I presented in American Diabetes Association last year. So effectiveness of AI-enabled digital precision care and remote monitoring in improving glycemic and cardiometabolic parameters in type 2 diabetes. So as I said, it can't be done alone. I have a team and called Credo, or the group of people whom I engage, not in all patients who are very willing. So that could be the bias that people are already willing to do the lifestyle changes. Secondly, that Hawthorne effect happens. So someone is monitoring you, you get better, isn't it? So even that effect itself is good. We are using that to our advantage to bring healthy lifestyle changes in our patients. Again, I won't run into the methodology. Again, willing patients, it is a paid subscription for about, it doesn't cost much. Each, of course, the twin and other things are much more expensive. And setting personalized goal for nutrition, fitness, and lifestyle modification is the key to it. And most importantly, the compliance with the medication also improves with that. Once someone is seeing and asking, did you take all your medications? So those people who are not taking also take. And I'm sure we all know in practice that half the time or 20-30% of the time, definitely the patients miss the medication itself. And that itself can worsen their outcomes with respect to glycemia or CV outcome. So all these small bits adds up and gives a definite good result to the people. So this is the member app again regarding the exercise, diet, medication, what they, I'm sure all of you know it. You need to just add and click photo and send it and so on. Happens. And also a doctor's dashboard, they alert only if there is a problem. Gestational diabetic patients are the one who religiously follow all of this. After that, they forget about it. But again, the doctor's dashboard also is very crucial. If someone is having sudden high or low or nocturnal hypoglycemia gets picked up. And when we see a post-hypoglycemic hyperglycemia, many times we may increase the dose rather than reduce or modify the dose. So all these factors are very, very useful in our day-to-day clinical practice. So what are the results? If you look at the results, the gender distribution, 60% of my patients were male. And very interestingly, I don't know if it is the Bangalore effect, above 60, also 21% of the people were there. So that is one heartening thing. Technological stuff, generally, people with age will not accept it, but maybe because of the tech or their kith and kin who will motivate them to do it or do that on their behalf, many of them were willing to take even the elderly age or beyond 50 years also. We had a good number of patients. And new onset of diabetes, they are very interested in all these things. I want to reverse it off and so on. And more than 10 years diabetics also they were about 28%. And another set of people is gestational diabetes and people whom you are contemplating insulin use. They said no, to avoid that, they take it as a defense mechanism. So all the results, I put it up in one slide. The weight difference after 30 days on an average were almost nearly 3.8 kg difference. And A1C reduction was 1.7. And among the lipid parameters, triglycerides showed a statistically significant reduction in the parameters. What we generally expect with better control of diabetes and weight loss. So I think I'll not go into this. This is just the split of all this because of the want of time. And this is what I wanted to emphasize. Adherence of the patients to medications and lifestyle modification goes up. And that itself is good enough to give good results with respect to cardiovascular outcome and the glycemic. So friends, to conclude, treatment, patients' involvement is important. They have to be their stakeholders and take responsibility. So the treatment continuum happens when we do this. Technology is always there to bridge this and help us out. AI-enabled digital precision care and remote monitoring is the way forward. Most instances, we should be able to do it at least in the metro cities and there. And I think there are better ways of getting it done, and it gets cheaper with time. And definitely, we always need a long-term studies to know how effective they are. In the one aspect I would like to say is 3 months they renew. After that, the renewal will be much lesser. Only about 20-25% of the people will renew it. I tell it's fine. When you use this up, not only the patient, but also the whole family benefits. The family's dietary pattern also changes when we do that. So I tell this will be a primordial prevention step towards also. Thank you.
Thank you, Dr. Manohar, for being most motivating person in the room and underlining your presentation with practice what you preach. Thank you very much. Now we have to welcome another equally lucid presenter, Dr. Suhas Erande. May I welcome him on board. Thank you very much.
A very excellent practical talk by Manohar. My work is actually fairly started already, if I may use that word. Thank you, Manoj and Purvi, for their continued affection towards me. And I am very glad that I am into a very practical session on the 40th anniversary of the famous DCCT trial. I will be talking in a very boundary kind of thing. So some guidelines and some limitations I have. This is the impact of food-based dietary strategies on achieving type 2 diabetes remission, which is the flavor of the last few seasons, I would say. So the Mediterranean and plant-based, etc. So this is on one side of the story. We are aiming at use of the technology like CGM to better do a good diet, maybe other lifestyle factors as Manohar just now told us. But are we taking a step too far? This is the Lancet Diabetes Endocrinology editorial this month. So this says that the promotion of CGM for non-diabetic people is something which is not evidence-based. It may precipitate something like a eating disorder also. So we have to actually be a bit, you can say, taking the things not too far. That's what LDE people say. Our own experts who can be a better expert than Professor Mohan, our esteemed teacher, and our own organizer, Dr. Manoj Chawla. So they have actually given us our own Indian situations or take on this, and they say that use of CGM helps in adjusting diet, physical activity levels by minimizing the hypoglycemias as well as hyperglycemias, and newly diagnosed patients who are reluctant to start medication. This can certainly be of great help, so that at least the diet therapy can be very, you can say, robust in these kind of situations. I always explain to the patients because they are always going to claim that, okay, my diet is very good, I am very disciplined, etc. But still the sugars are high. And none other than Manohar himself has actually showed his own record right now. So there are very many things. And what we are actually not mentioning even in this exhaustive list is the microbiota, which also these days are going in extreme details to show the dissimilar responses in age, sex matched people, similar A1C, similar duration of diabetes people. Same food can give you different kind of glycemic repercussions in their CGM records. So some hidden things are microbiota, and some could be even probably the dietitians may not reach this area. So food additive emulsifier, this is a very huge study, and there are very many food emulsifiers
though this may not really apply to the home cooked food in a strict sense, but commercial and industrialized food, ultra processed food, this certainly applied, and that also needs to be brought to the notice of our patients. I have brought a very ancient slide. This was an assessment of 7 countries. Of course, this was from CV protection point of view, 1950s. And you will see that the vegetarian and non-vegetarian, different kinds of intakes from different European and especially US also. And we actually learned from all this. So we have to have a biological feedback to alter or improve the health related behavior. There in the CGM really is helpful. So providing individuals their own biological data, either directly through Holter monitor, CABP or a CGM, or indirectly through the health coaches, lifestyle advisors, or we also, that is something which is to be done. Aim is to support the health behavior change implicitly and to improve the health related outcomes explicitly. Biofeedback gives feedback only on one's autonomic nervous system to treat the health condition. So biological feedback is very, very important. And then there are very many groups. Actually, this slide I have specifically brought here to show us that these days we not only use CGM on dietary guidance for diabetics, but GDM, pre-diabetics, even the obese and all those, and of course different types of diabetics. But I have already told you that for non-diabetics, it's not really very much advisable. And then there is a method of CGM binding, modes of operation, channels, etc. The essence is to navigate the patient through their dietary therapy for control of their hyperglycemia. And this is the ADA guidance on using diabetes technology. They insist on use of real-time CGM for all this. In our country, we may not really be using real-time CGM in a strict sense of the word because quite a few patients may not really afford it. But wherever possible, we certainly should be using it. This is again the ADA, using continuous glucose monitoring to guide the nutrition and the nutrition counseling for the patient. And there is a published study also here that CGM is an attractive alternative to systematic blood glucose monitoring because the frequency can be uncomparable. CGM reduces the frequency of finger pricks and very importantly, the glycemic excursion minimization. That's the GEM trial and that has been actually very successful. So teaching people on which cues, only the CGM cue or even the eat according to appetite. That is another way of treating and teaching the patients. And then there are approaches used in different sets of people. So for example, type 1 on insulin pump also can be taught on these CGM guided nutrition. So we have to discuss the ambulatory glucose profile or CGM report with the patient, if possible with the family and the caregivers. Details of the meal timings, food choices like likes and dislikes, general food details need to be really appreciated. And again, Manohar has told us the importance of which food but at what time. And a recent publication has told us that something between late morning, so 9 a.m. to maybe around 1 p.m. That's the time when you should eat. If you really want to have a largest meal of the day, it should be in that particular time frame because that gives a better glycemic outcome over a long period of time. Ask if the patients have noted any AGP spikes on their own and hypos also, and introduce diabetes plate method, which is very easy for explanation, maybe pictorially more, or maybe even on a dining table of the patient. Lot of our, you can say doctors also use it and lot of dietitians also use it. CGM is very important for people with diabetes who are more keen to know what can be eaten and what, because normally what we tend to advise them is these are the items which are to be avoided, but they may be interested in what can I eat. So not every person with diabetes can see a dietitian and not every physician can afford to have a dietitian on a payroll. So these are the, CGM can certainly be something which is a mediator. Of course, if you have a dietitian on board, nothing like it. Dietitian can spend more time with the patient to guide on the nuances of cooking methods, timing, types of foods, eating out. For children, maybe the tiffin to be taken to the school, even for working people to tiffin to be taken to the workplace. All these things can be guided. But generally, we actually, as a physician, what I try to really emphasize is carbohydrates which are complex with fair amount of fiber, proteins which are preferably plant-based and first class, and fats which are not saturated or trans fats, containing more of MUFA preferably. So that's something which is to be emphasized. Give a list of different food groups and food exchanges. The recently published ICMR Indian diet, lot of pictorial presentations, lot of good tables which are very easy to take it to the discussion table with the patient. And very importantly, I will tell you, very importantly, the responses to wheat, rice, potatoes, sucrose, fructose, glucose consumed, whole grains, legumes, etc. That is something which you can actually put the chart on one side, put the CGM record in between, and you can easily explain it to the patient. I usually give lots of charts to the patients. These are ready reckoners which the especially the lady of the house can always make it use of, and additional discussion points, pick one meal at a time. So if you are discussing the AGP report on the CGM record, so focus on the breakfast, focus on the lunch, focus on the dinner at a time, or first focus on the meal which has the highest postprandial glucose excursion. So that's a very practical way. And then strongly advise keeping a food diary, because documentation can be important. Let's confirm that the patient is not cheating on anybody else and you. Teach the patients to look at a time in range. Teach them to that. So make the patients think and walk like you, and encourage the curiosity. If the patient, there are lots of patients who want to experiment. Okay, so try quinoa, try oats, whatever. So whatever fashionable foods or trendy foods, they can do it when the sensor is on, because the effects can be certainly appreciated by the patient and the family, and then they can maybe continue, discontinue, or do a adequate, let's say, modification in the same. So before any medication change, ask the patient whether he is willing for nutrition change. Every visit, as far as I am concerned, I ask the patient to come to me more often, especially when he is on sensor, because I actually try to consult and counsel them more number of times. So that's something which is my selfish end. But Professor Mohan has actually shown this as a very simple example. So simple rice compared to brown rice. And he has shown here, and published also in his center, that if the patient chooses more of brown rice, more fiber, then the glycemic excursions are relatively lesser compared to the plain polished white rice. And then if the patient is really using maybe something like Libre 2, then there are trained arrows, and trained arrows certainly tell us how whether the sugar is stable, whether the sugar is rising rapidly over a period of time, and those foods which make that arrow go perpendicularly up, or if it's a Dexcom, then double up, then that food is certainly to be avoided. This is something which the patient can very easily appreciate, and you find it very easy to explain also. And these are the some details. Of course, for lack of time, I won't really be able to go in the detail. But the first is something which is a fair response to insulin. The second is where probably the insulin needs to be taken reasonably prior to the meal, depending on which whether it is a RHI, whether it is a routine aspart or a fast-acting aspart. You have to tell that. The third example, C, is the insulin dose is adequate, and the fourth, of course, is where the insulin dose is high, and you have to reduce that. So you can yourself learn some lessons. Some of the examples which I have actually brought here, this is a Teki himself. So he's around 40-year-old man. 7 to 8 years of diabetes, mostly on multi-dose insulin for last 4 or 5 years. And because of his foreign tour and foreign job, he couldn't really attend the clinic. HbA1c had gone up, as you can see, 9.9. He's something which is not LADA, as Narayan had said, but he's body mass 25, but he's highly motivated. And you can appreciate here that repeated counseling, repeated sitting with the patient, sending photographs, trying to make use of the photo-assisted interpretation of the calories in the food. All those tricks we have tried, and ultimately we will see that through some hypers and through some hypos, we are fairly able to, you can say, stabilize the reading. And all of you can certainly appreciate this day-to-day record of this particular patient. This is a different example. He is somebody who is alcoholic pancreatitis, following which he has got a diabetes. So he is essentially on multi-dose, and general dose is around 40 units of Iglar, 300 Fias 23 times a day. And he's a restaurateur, a businessman, so his meal timings are erratic. But he keeps sending the AGP graphs 3 times to me on my WhatsApp. We tried to modify his insulin dose, and we also have tried to, you can say, regularize the timing of the meals, the coordination or synchrony between the insulin dose and the meal. And then probably over a period of some time, you can see here that we are able to fairly, you can say, normalize his glycemic excursions. So very, very important. Now this is another example, fairly newly diagnosed lady, averse to allopathic medications, but she is ready for diet and exercise, etc. She visited on day number 369, consulted with our dietitian also. A1C is diagnosed, A1C is 8.5, something of that kind, but very importantly, she is not no therapy, and still we are able to fairly control that. Another example, 55-year-old obese person, comorbids, and IDA gas dose increased from 40 before breakfast to, you can say, 30 BID. Diet revisions with the dietitians have been done on different days, and he has now stopped taking the diet cola. He works late nights. His office is US, but he is in India. So it's fight against the biological clocks or circadian rhythms also has been actually curtailed, and he has now actually resolved. He has asked for the 90-day sensor to me, but we are, as you know, we don't have it right now. But he has already expressed his willingness there. And then this is a newly diagnosed diabetes. One son of one of my patients was working in US for 4 or 5 years, now has come back to India, and very easily you can see, those of you who are experts in AGP, you can easily see here that the pale blue, or what we call it as the interdecile range, is quite huge in this patient. And the reason here is he works over the night and he sleeps during the day. And gradually he also has actually started doing a good diet. Of course, he has been started on metformin twice a day, and he also is something who, really speaking, had curtailed lots of coffee and lots of diet cola and so many different things, which apparently were quite innocuous for his impression. But now he has certainly started responding to the tune that he is going in hypos now. This is just to show you that every day, this is my selfish nature, the patient is being called every day. We see the graph and we see that different dietary items. You can easily see here that sabudana vada and all is being consumed by the patient, and that still is giving some spikes, so to say. And every day there is some kind of modification in the diet which we are making, and this is strictly guided by these continuous glucose monitoring records. And different examples, again, for the lack of time, I will not go into the details, but appreciate that the diet is here, the record is here. So it becomes quite, you can say, smooth, easy for us to explain to the patient. This is the survey which we are taking, what the patient's impression after doing the CGMs, and what are the different changes, not only in the food, but in their exercise, in their regularity. Are they willing to really do it? And the responses are quite encouraging, so to say. German diabetologists have done a training program for the people who are doing this. A step between my limits, no CGM for the non-diabetics, but now we are talking about something which is a pre-diabetes and diabetes, but in between there is a early diabetes or advanced glycemia, and that advanced glycemia certainly qualifies for a CGM record. And then these are the photographs of the foods sent to the dietitian or to you, and the app of Dr. Kulkarni that will certainly help us telling the details of the carbs and other, you can say, proteins and everything here, and adding a brief CGM even to a national diabetes prevention program has been published. So though we are limited in the, you can say, limits of CGM and diet guidance, still people are pushing the boundaries now. And how does diet change at the diagnosis of diabetes? These are again the questions, and these are the DASH diets. You can always use this. Easy fruits, vegetables, etc. Adequate fruits, adequate vegetables, more plus points, and more sodium or more red and processed meats, negative points. And then 40 is the ideal score of this DASH diet. You can always use that. Last, carbohydrate distribution and the effects on the glucose peaks. I have already told you that the mid-morning or breakfast, if you really put the carbohydrates more in that, and then maybe spare some carbs in the lunch and hardly any at the time of dinner, they say that the overall glycemic controls are certainly better. Friends, thank you so much for your kind attention. Thank you so much.
Thank you, Dr. Suhas, sir, for such an informative and tailored speech on CGM we can use to modify that, not only treatment, but modify the diet also. Any questions from the audiences? Yeah, please.
Hello. So I'm Dr. Anil Hardas. Sir, always we are in a doubt whether the patient is pre-diabetic or no. One time it's fasting sugar when PP comes borderline just about 140, 145 maybe. And sometimes fasting sugar comes about 115 also. So the patient himself is confused. But I think CGM in pre-diabetic would be the best modality to diagnose a gray area of pre-diabetic. They're your comments, please.
Absolutely. See, if you are in a query for defining a person who is maybe IFG, IGT or both pre-diabetic classically, technically speaking, you just maybe lifestyle, everything you do, rule out that he already has any kind of ASCVD risk factor or a comorbid so that you are not wasting time. But over a period of time or looking at the trends, you can certainly define whether he is a classic pre-diabetes or rapidly going for development of type 2 diabetes. That's certainly because CGM ultimately CGM is only 14 days.
And
right?
so also CGM will help us to know how much rapid acting insulin we have to use versus the basal insulin.
Certainly.
Ratios.
Certainly. You are absolutely on the ball. Thank you.
Thank you, Suhas sir. We'd like to move the next lecture. I would like to invite Dr. Arun Kedia from Raipur, who's going to speak on prevention of Charcot arthropathy. Mic to over you, sir.
Good morning, everyone. So as we move towards the end of this 3-day extravaganza, I would take you to a serious topic, that is prevention of Charcot's arthropathy. It's always a pleasure to be in Mumbai, my alma mater, and I can see my professor, Dr. Andy Maulik, ma'am, just entering into the hall to listen to my lecture, and that's my privilege. Thanks to Dr. Manoj and Dr. Purvi to give this opportunity. So Charcot's arthropathy, I say it's a serious matter, not because the disease is serious, but it's because the attitude of the doctors as well as the patients towards the disease is not very serious. And that's what makes the disease much more serious and a need to discuss Charcot's arthropathy. So we all know that we have a poor diabetes control. Average HbA1c in our Indian patients is more than 8% and not more than 30% of the patients have HbA1c less than 7%. We also know that the prevalence of diabetes complications is proportional to the HbA1c, and we know that each 1% reduction in HbA1c leads to a reduction in almost 40% incidence of microvascular complications. So when we discuss Charcot's arthropathy, it's basically a combination of both micro and macrovascular complications, essentially microvascular complications, because we want to prevent diabetic peripheral neuropathy, because that is the harbinger for the development of Charcot's neuroarthropathy. And if you see the prevalence of complications in type 2 diabetes patients, you can see that the highest complication is diabetic neuropathy, which we generally do not address very much. And we are more worried about the macrovascular complications, the cardiovascular death, but we hardly pay attention to the development of diabetic neuropathy. So with this background, let me just take you to the definition of Charcot's arthropathy. So it's basically non-infective, progressive, destructive disease of both bones as well as joints, resulting into a fracture or a dislocation, or maybe both in a patient who has insensate joints or a peripheral neuropathy. So the background for developing Charcot's neuroarthropathy has to be a peripheral neuropathy, and that is where the prevention will lie. And if you see the epidemiology of Charcot's arthropathy, again, the exact incidence is not known because we actually do not diagnose it at the first stage. But there are some studies which say that the incidence and prevalence varies between 0.3 to 0.4%. In less than 10% of the cases, the disease may be bilateral. Of course, more common in type 2 diabetes patients because the new microvascular complications actually start before the diagnosis of diabetes. And there is a slight gender male predominance because the males are known to have more trauma in terms of their day-to-day activities compared to the females. Now, the most important part is to understand the pathogenesis because it is not only a simple neuropathy. The background is autonomic neuropathy also along with peripheral neuropathy. And now as we evolve into learning more pathogenesis, we have also found that there are some genetic associations because not all patients with peripheral neuropathy will develop Charcot's. So you have a patient with a background of neuropathy upon which there are repeated trauma, microtrauma, which leads to an inflammation. And this inflammatory cascade in a patient who is prone to develop Charcot's is decided by genetics. And this inflammation leads to metabolic abnormalities. Ultimately, there is a cytokine storm and there is a destruction of bones and joints. So what you have, a regular feet actually turns into a rocker bottom feet over a period of years. And this is a manifestation of not only sensory or motor neuropathy, but also autonomic neuropathy with a combination of trauma, and then there is a fusion of bones. So if you see the evolution of understanding of pathogenesis of Charcot's arthropathy, we initially had a neurovascular theory, which lasted from 18th century. And then we came to the neurotraumatic theory. And now we are talking in terms of molecular biology, where we have seen that inflammatory cytokines are the ones which actually lead to the destruction of bones as well as the joints. So we need to understand that there is both inflammatory and non-inflammatory pathway, which actually leads to stimulation of osteoclastogenesis. So the final pathway is actually osteoclast activation, which further leads to bone destruction. And ultimately, in a background of hyperglycemia, you have both inflammatory as well as non-inflammatory pathway to lead to the destruction of the joint. So this is the well-known anatomical classification, which I'm not going into the details because that is not relevant for today's discussion. But what is important is to understand the Eschenschall's classification, which actually tells you the stages in the evolution of development of Charcot's arthropathy. So if you have stage 0, where the patient just presents with joint edema, where the x-rays are negative and the bone scan may be positive in some cases. But you have stage 1 and stage 2, where you have fragmentation and coalescence, which are picked up on x-rays. And then you have stage 3, where the disease becomes inactive, but actually the patient has gone into an irreversible stage. So stage 0 joint edema is the one where we clinicians need to focus on, because this is the stage where we can do a lot for our patients. So the good clinical practice guideline says, always consider active Charcot neuroarthropathy in a patient with diabetes, neuropathy and intact skin when there are clinical findings of an increase in temperature, edema and or redness of the food compared to the contralateral food. And here lies the use of infrared thermometry. Because if you find that there's a difference in the temperature between the contralateral limb and the affected limb more than 2 degrees Celsius, it is almost considered to be pathognomonic for Charcot's arthropathy, and you can straightforward put it as a clinical suspicion even when the x-rays are normal. Why I say this? Because we don't have access to MRI for all our patients, or sometimes the patients may not agree to go for MRI whenever we suggest them. Now, stage 1, stage 2, and stage 3 can be picked up very well on the X-ray. On stage 1, you see fragmentation of the bones, you get joint edema, and you get a combination of various dislocations and fractures, which can be easily picked up on X-ray. And then stage 2, you have coalescence, where you have sclerosis of the bones, there is fracture healing, and there is resorption of the debris of the fractured bones. Here, the patient presents with decreased joint stability and decreased mobility. And finally, you have the healed up joint, where the patient develops consolidation and remodeling of the fractured segments. And these patients develop what is classically called as a rocker bottom deformity, because most of the time the patient's medial arch gets collapsed. And that is where the patients now become very prone to development of ulcers. So by and large, when we talk about the incidence and prevalence of Charcot's arthropathy, we actually diagnose most of the patients in this stage, and that is where we do not want. So this conference, where the theme is prevention of diabetic complications, it is my advice and my take-home message that we need to diagnose it right at stage 0. That is where we can actually make a difference to the patient. So the early clinical presentation is the one where we need to focus on, and any patient who presents with peripheral neuropathy with a swelling in the ankle or foot may be painless or painful with some loss of function, you keep a suspicion of acute Charcot's. Of course, you have to keep various other differentials in mind, but please do keep this as one of the most important differential whenever you have a patient presenting with unilateral limb edema with some raised temperature. Of course, this is what we don't want, the late clinical presentations, because most of these patients will have loss of functional mobility, and this is a typical appearance of what is called as a rocker bottom deformity. So when you have a patient with suspected Charcot's, there is an important algorithm which we need to focus on. So you go for an X-ray. In stage 0, as I said, the X-ray may be normal. If the patient is willing and if you are able to convince the patient to go for MRI, then you can very well document bone edema in all these patients, where you can clearly label these patients as Charcot's and start the treatment, which is going to be offloading. However, if the diagnosis is something alternative, then you can switch over your diagnosis to the other one and you can treat the patient accordingly. So the most important part here is to differentiate between infective and non-infective. In majority of the patients, whenever we find that there is a rise in temperature, we think it is an inflammation due to infection, and we keep on treating them with antibiotics. We keep on changing the antibiotics, but the patient doesn't respond. And that is where we need to again understand that it is we who are wrong, not the patient. So always try to focus on MRI if you can for all these patients. So these are the differential diagnoses which we always keep in mind: cellulitis, osteomyelitis, septic arthritis, sometimes gout and pseudo-gout, and most important is a deep venous thrombosis, which can be easily ruled out with simple investigations, and you don't need to go for very expensive investigations. But if you suspect Charcot's, please focus on MRI if possible. So now the most important part of my presentation, that is prevention, and we know the models of prevention. They are primary, secondary, and tertiary. So primary prevention, as I said, the background is a peripheral neuropathy. So we need to have an early aggressive glycemic control whenever we diagnose type 2 diabetes patients. We need to start education for foot care for all our patients right from the day of the diagnosis of diabetes. We need to educate the doctors to identify Charcot's early, and that is why probably Dr. Manoj gave me this topic. And we need to understand for early referral to specialists whenever we are in a dilemma to diagnose Charcot's arthropathy in all our patients. So we need to have a high index of suspicion. We need to have clinical methods to examine skin temperature, preferably using an infrared thermometry. And then whenever we suspect them, even before we start any other treatment or diagnosis, we need to start telling the patient about immobilization of that particular knee, limb till the time we actually come to a conclusive diagnosis. So once we have diagnosed Charcot's, we need to have secondary prevention now. Secondary prevention is basically to prevent the development of deformity. And here we need to use certain devices to immobilize the patient, and we need to offload the limb. So we have certain options. You can use a non-removable knee-high device. You can use a total skin cast or a total contact cast, what is known as, or you can use a knee-high walker, or you could use a removable knee-high device. Now here the controversy lies whether to immobilize the patient completely or give them partial mobilization, because immobilizing the patient completely may lead to muscle atrophy. It can lead to discrepancy in the use of muscles of the two limbs. So there is an option that you can give some mobility to these patients using a knee-high device with some walker facility. But we need to avoid use of below the ankle offloading, because that is not going to prevent the deformity development. And one can use also assistive device to reduce weight bearing on the affected limb. So these are some things that we need to advise to all our patients whenever we want to prevent deformity. And remember that this offloading and immobilization has to continue till the patient is in remission. And I'll talk to you what is remission. This can take 3 months to 1 year. So you have to counsel the patient again and again, because this is the part where the patient will not agree to you so easily. Any role of drugs at this stage? We have tried a lot in the research, because as I said, the background is inflammation, osteoclastogenesis. So we have had uses of methylprednisolone. People have tried denosumab. People have tried teriparatide to reduce osteoclastogenesis and improve fracture healing. But all these have not translated into improvement in time to remission. And that is why the good clinical practice guidelines does not endorse any of the molecules right now. And probably that is the reason why we neglect Charcot's arthropathy, because there is no use of any drugs. No pharmacology, no pharma companies ever focus on the development of Charcot's arthropathy. But important in our condition is to advise the patients on improved calcium and vitamin D intake, because that is the one which can improve some fracture healing and some reduction in osteoclastogenesis. And this was a paper by Dr. Ashu Rastogi where they did a meta-analysis and they clearly mentioned that there is no role of any pharmacotherapy as of today for treating Charcot's arthropathy. Now, once the patient is agreed for secondary prevention, we need to follow up. In follow-up, we need to keep on monitoring the skin temperature. We need to look for edema. And whenever the edema keeps on going down, we need to keep on changing the skin cast. That is very, very important. And we need to see not only the reduction in edema, we also need to see the change in temperature, and we need to do serial MRI, if at all, to see whether the patient is completely into remission. And for that, frequency of visit of the patients to the doctor may vary from patient to patient. And that is where, again, the counseling of the patients is very, very important from the doctor's end. Coming to the last part, that is tertiary prevention. Here, the patient has already developed deformity. Your job is to prevent ulcers now, to prevent infections, and to prevent amputations. So here comes the role of surgeons, and especially orthopedic surgeons who are trained in managing diabetic foot. So surgery would be advisable in patients who have instability of the foot, or where the patients have a deformity which can lead to ulcer even in the presence of offloading device, or a patient who has pain who cannot tolerate that pain. Of course, if the patient has undergone a conservative treatment and is in remission, then one can advise them footwear or orthosis, which will prevent further offloading and which can prevent the development of ulcers in the future. So remission, and trying to define remission again is going to be a tough task because we do not have an exact criteria for remission. The last part, barriers of prevention. So we still do not have a diagnostic criteria for Charcot's arthropathy. Whatever we have is a consensus. It is not a diagnostic criteria. We, as of now, do not have any biomarkers to define Charcot's arthropathy. There's a lack of knowledge amongst physicians to diagnose Charcot's arthropathy. There is often a delayed diagnosis, and most of the time patients land up when they have already developed deformity. Total contact cast and immobilization is still not acceptable by majority of the patients because it reduces their work time. There is a lack of surgical expertise for tertiary prevention, and the most important lies in the background that there is still poor glycemic control in majority of our patients, which is a significant barrier for the development of prevention of peripheral neuropathy. So the take-home message for this talk is consider it as a serious and potentially limb-threatening complication. It can lead to dislocations, fracture, infections, ulcers, and amputation. We need to have correct early diagnosis and treatment. Offloading, immobilization is the key to management. Lifetime surveillance of those patients who have recovered, because I said that once the patient is in remission, he is still at risk of developing ulcers. So we need to keep a lifetime surveillance. And the most important key would be early aggressive glycemic control and prevention of neuropathy, which will be the key to actually prevent all cases of Charcot's arthropathy. So with that, I thank you all, and I would request you all to go through this International Working Group of Diabetic Foot Guidelines. It has incorporated a separate guideline for managing and preventing Charcot's arthropathy. It's almost a 40 pages consensus statement, and it would be a good reading for all of you. Thank you for a patient listening.
Thank you, Dr. Arun, for a very nice description of Charcot's arthropathy, which is diagnosed very late many a times. Thank you. Now I call upon Dr. Purvi Chawla to share her views on non-nutritive sugars. Purvi Chawla doesn't need an introduction. She is the whole and soul of the program.
Thank you so much. I'm so happy to see all of you. Hope you have enjoyed the 2 days of academics and the third day today. And I'm grateful to Zydus for wellness for this session, because I think it's an important one. We have been inundated with queries, right, when the WHO report came up, and it was quite difficult, or it was quite urgent that we all needed to get some facts around what was actually happening and burst the myths around the non-nutritive sweeteners or the non-sugar sweeteners, and sort of inform the general public also exactly as to what was happening. So without much ado, yes, these are compiled facts from scientific data. And again, I think this introduction is not necessary, but let's start that, of course, sugars, simple carbohydrates are a great source of energy, but they also increase the caloric intake and also initiate a vicious cycle where, because of the insulin and other hunger hormones, you're going to feel more hungry and seek more of that kind of food. So sugar consumption, in fact, in India has grown massively or exponentially and is approximately 25 kilograms per person per year. And as opposed to the world per capita consumption of only 23 kilograms per year. So it's a massive, massive increase in sugar consumption in our, developing nation. I don't think we can afford to have this kind of sugar consumption. And the 66th round of the NSSO report in 2009-2010 reported a 151% increase in white sugar consumption per person per day in India. So it's, these numbers are staggering, and it really it's a call to action that limits sugar, but somewhere we're required to replace it. I think non-nutritive sweeteners become a good option that we have to do. So sucrose, glucose, fructose are the most common nutritive sweeteners used in food and beverages and add up to 4 kilocalories per gram to the food ingredients. Added sugars, yes, the sweet poison, and we know they're all over in the processed foods, in the absolutely sweet tasting desserts, and there is an array of everything, and it's not just for those with diabetes, but even those trying to lose weight or just those who don't, just maintaining good health. For everyone, added sugars is a poison. The adverse health outcomes of high sugar intake is not restricted to just diabetes, hypertension, or insulin resistance. I think an important box here is that which has metabolic dysfunction associated steatotic liver disease, the new entity that has been really being talked about now, because we are realizing that it's harming the liver and then the subsequent pancreas and the ramifications all over. That is something that is really to take account of. And of course, the association with gut dysbiosis and also other grave diseases, including cancer. So WHO reports that free sugar intake has increased overall energy intake, and that may lead to an unhealthy diet, weight gain, and increased risk of non-communicable diseases and also dental caries. And it's important to limit sugar intake for the same. Now, why all this jargon? Because non-nutritive sugars or the low caloric sweeteners become a good replacement to cut down the calories, provide the sweetness of the taste, and still give you an option where you want to limit the absolute sugar intake. So yes, it's an alternative, and the journey is more than 100 years old. The first non-nutritive sweetener was actually discovered in 1879, which was saccharin, and I think all our grandfathers probably were used to those saccharin tablets. But since then, we have had a splurge of innovation over here also, with stevia being discovered almost 95 years ago, aspartame, asulfame, sucralose, and the last in 1992 called neotame. Characteristics of various non-nutritive sweeteners, again, most of them are almost a few hundred folds sweeter than sugar, and that's why we need a very small quantity as far as taste is concerned. They're usually in the salt form and give 0 calories or minimal. Like for example, aspartame gives just 4 calories, and the acceptable daily intake is quite high, which gives us a good leeway to use them in our daily lives. And the metabolic properties are, most of them are metabolized and then excreted unchanged. So now let's come to the crux of the talk, the myths versus the facts, the myths around the use of non-nutritive sweeteners. And to understand this better, I think there are two concepts which I want to share or remind you all of. One is the acceptable daily intake. Every time we talk about different elements of food, we must define this acceptable daily intake. It is the estimated amount of a food additive expressed per kilogram of body weight that can be ingested daily over a lifetime without any appreciable risk to the human health. So that is acceptable daily intake. And NOEL, or no observed adverse effect level, is the highest dietary level of the product, in this case it's non-nutritive sweeteners, at which no adverse effects were seen in animal trials, which means that beyond this dose there were adverse effects seen, and this was completely clean. So NOEL is a very important term when we are defining what is the correct quantity to have. And the acceptable daily intake is NOEL and 1/100th of that. So you see there's a huge safety margin as far as non-nutritive sweeteners go, or for that matter, any of the food additives go. Of course, we know we don't want to overdo anything. So now, based on this acceptable daily intake, as per the joint FAO and the WHO Committee for Food Additives, stevia glycosides have the acceptable daily intake of 4 milligrams of steviol equivalents per kg body weight per day, aspartame 40 milligrams per kg body weight per day, and sucralose 5 milligram per kg body weight per day. Coming to the first myth, well, it was thought that they are going to increase the risk of cancer. And 10 years ago, the US FDA reported that generally speaking, they are safe under the conditions that have been approved for use. And this was further supported by the American Cancer Society a few years later when they gave out a statement saying all NNSs appear to be safe when consumed in moderation. So that's the key, consumed in moderation. And what they based their statement on was an earlier study which said that on examination of human data from an NIH AARP diet and health study of over 500,000 retirees, they found that increased consumption of aspartame-containing beverages was not associated with the development of lymphoma, leukemia, or brain cancer. And further systematic review has also shown us that sucralose is unlikely to be carcinogenic in humans. Keywords, consumed in moderation. Moving on, there were other further studies in preclinical species of steviol, sucralose, aspartame, and sucralose again, all leading us to understand or coming out with the same conclusion that there is possibly low genotoxic or carcinogenic activity, and they are actually not considered carcinogenic in humans from all the consumption doses that were given in these studies. The next myth, it alters gut microbiota. And I think we have heard enough in the other halls with respect to that. But the fact is that the expert consensus on NNS have suggested that human studies are actually limited to providing us with that adequate evidence that NNS influence gut health at doses that are relevant to human use. See, the wording is very, very clear. Today, sugar itself is associated with gut dysbiosis, and we know it's an absolutely well-established fact that overconsumption of sugar is going to cause gut dysbiosis and going to lead to obesity, diabetes, pre-diabetes, and a whole lot of metabolic diseases. However, with NNS, when consumed in moderation, it may have no effect on the gut microbiota. Again, this was from the fact that animal models have not shown that NNSs do alter the gut microbiota, and a recent human study reported that daily intake of pure sucralose or aspartame in doses that could be considered as high for human consumption also were not shown to have any impact on the gut microbiota. And there's further data to support that the mean Shannon diversity index, which Dr. Talukdar also referred to, and it shows how diverse the gut microbiota is. Again, there was hardly any impact with sucralose or aspartame. But let's take it with a pinch of salt. Let's understand that we actually need to really limit our consumption of all these, and in that limited quantity it may not alter anything in our system that will cause any further damage. Now the next important myth is that it's associated with chronic kidney disease, and the National Kidney Foundation's guide planning for emergencies and a guide for people with chronic kidney disease recommends adding artificial sweetener as a part of an emergency diet plan. So they are not endorsing that simple sugars are added to the food plate, but NNS is okay to use. And this is for patients even in CKD. So we know that meta-analysis of randomized control trials, that's probably the highest level of evidence that we can generate, because we know randomized control trial is one, and meta-analysis usually looks at everything together. Of course, a lot of conditions apply, but by and large, this is the highest level of evidence. And they looked at association between sugar or artificially sweetened beverages and the risk of CKD. And they found that actually sugar sweetened beverages, so a pure cola or whatever, would probably increase the risk of CKD, would not probably, but would increase the CKD risk by 1.6 folds. But no significant association was found between artificially sweetened beverages and CKD. Again, like I'm saying, please take it with a pinch of salt, only in moderation. So what are the health outcomes with these? First of all, in that small quantity, there's not going to be any effect on glycemia. There is also prevention of dental caries as compared to sugar, and there is some amount of weight reduction or maintenance. And I think the whole entire WHO controversy came up, and they started saying that people who want to lose weight, it was not for diabetes, people living with diabetes, but it was more for people living with obesity and trying to lose weight. And, instead of sugar, trying to add a sweetener in everything that they eat. So that is what was being alerted against. So NNS has shown beneficial effects in the above conditions, as it helps in the reduction of added sugar and overall energy intake. And it does help us maintaining a healthy body weight, thereby lowering the risk of conditions like metabolic diseases and cardiovascular risk as well. In weight management, yes, observational studies in fact showed that there may be promotion of weight gain, and the hunger cravings or the sweet cravings would actually increase. And we know that that probably is a fact, but again, the consumption quantity is important to understand. But these were observational studies. What do randomized control trials say? That they actually support weight loss and maintenance by reduction in the intake of sugar-containing foods and also reduction in the total energy intake. So in evidence-based medicine, like I said, randomized control trials are definitely better than observation studies, and again, meta-analysis of randomized control trials is probably the highest level of evidence that we accept. So again, several studies have also shown that there was no significant weight gain, or in fact, energy intake was reduced with the use of stevia or aspartame, and weight maintenance was observed. Again, this is just to show that meta-analysis evaluated the effect of NNNs, all of them, on body weight, and reported the following results. Some said that there were highly inconsistent results. It is difficult to actually study food additives or dietary patterns. It's very difficult and challenging. But still, more or less, it showed that no association between NNS intake and an increase in body weight, BMI, etc. And more so, it showed some positive relationship between NNS and weight gain or increased BMI. So what exactly happens? Excess sugar intake on glycemia. We know that with prolonged excessive sugar intake, there is also increased fat storage around the liver and then spill over to the other internal organs, increasing the insulin resistance in the liver, in the pancreas, in the muscles. And then we know that there is progressive deterioration of beta cells that happens with that, and then development of diabetes. As I described it very simply, but it's a very complex molecular mechanism. And how do the NNSs impact it? They don't impact it if they are taken in that small moderation or small moderate quantity. Again, several studies have proven that there may be no impact at all, but anything more than that will definitely impact it in the wrong direction. Now, this particular meta-analysis suggested that blood glucose levels gradually declined over time following the NNS consumption. And this was around 741 participants in all from 29 randomized controlled trials. And they examined aspartame, saccharine, stereosides, and sucralose, which we commonly use. And they found that there was no increase in blood glucose level. In fact, there was gradual decline in blood glucose concentrations over time and no effect on overall glycemia by the type of these NNSs used. In dental health, sugar actually metabolizes to acids and demineralizes the enamel, and that can be attacked very easily by the oral pathogens. So yes, it gives rise to not only that foul smell, but halitosis, but also cavities, right? But whereas NNSs do not get metabolized, so that risk of dental caries, which we see especially in high candy eating children, is or young adults or even older ones, is probably less with NNSs. A systematic review again revealed that limiting free sugar intake to less than 10% of the total intake of energy through the day reduces the risk of dental caries throughout the life course. This is irrespective of the brushing standards. Current status of NNS use, most of these are approved in hundreds of countries across the world, and they're considered by and large safe by the world. In India, what is the status? We have saccharine, stevia, aspartame, asulfame K, sucralose, and neotame. All of them are allowed as non-caloric sweetener in some of the food product categories specified by the FSSR. In particular, in aspartame, for example, was discovered in 1981 and was approved for limited use, and then that got expanded to even the carbonated beverages 2 years later, and then in 1996 it was approved as a general purpose sweetener. And sucralose and stevia glycosides have also achieved a similar status over time. EFSA statements on aspartame, sucralose, and steviol, and mind you, I'm talking about these because these are the most commonly used NNSs across the world. Aspartame was not of any safety concern at the current aspartame exposure estimates or at the ADI of 40 milligrams per kg body weight per day. Steviol glycosides, again, not carcinogenic, genotoxic, or associated with any reproductive developmental toxicity. And the established ADI was 4 milligrams per kg body weight per day. And so was the case with sucralose. And they looked at the relationship between consumption of sucralose containing foods and beverages and tooth decay also, and found that there is no increase in any of these, at least. In special populations, it has been largely approved for use in children and pregnant women. But this statement is very, very important, and I'm going to wind up very quickly. But let me just walk you through this. The ADA, or the American Diabetes Association, says the use of NNS has the potential to reduce overall caloric and carbohydrate intake if substituted for caloric sweeteners and without compensation by intake of additional calories from other food sources. So what it essentially is trying to tell us, that don't make mithai and shira and blah, blah, from these
Purvi.
NNSs. I'll wind up quickly. But it is okay to replace that, 1 spoon of sugar, 2 spoons of sugar that one might be used to taking in the beverage, tea or coffee. It's perfectly fine. But don't overindulge with the, high intake with all the sweets, etc. And just one more minute, the WHO advised us not to use no NNSs for weight control in the newly released guideline. And this is what riled up that entire controversy. But they later on released that we do not have enough evidence because of the background characteristics of all these studies, and the population that they studied may not be the same. So you can't compare apples and oranges. That's what they meant to say, and that we need more evidence to say. But in that, there were some key findings from that report. One is that randomized clinical trials have shown that there's a small reduction in body weight and BMI in adults with no changes in other measures of adiposity or cardiometabolic health. And they actually help reducing energy intake by replacing sugar. And of course, prospective cohort studies do suggest that, in fact, there might be increase in body weight. So overall, the quality of evidence is not very strong either way, but in small quantities, they are perfectly safe to consume. So in conclusion, India, we've seen that massive consumption, increase in the consumption of white sugar, and we have to urgently do something. This is a whole Congress on prevention. One is to replace that sugar or cut down that sugar completely. For replacement, we have a great option in the use of non-nutritive sweeteners. It's an effective strategy, and they have been approved for use as a food additive by various regulatory bodies, such as the FAO and the WHO, EFSA, etc. Clinical evidence does tilt in favor of NNSs being effective in weight control, diabetes management, and prevention of tooth decay. And safety of NNSs has revealed that NNS consumption is safe for use for the general population and also pregnant women and children. With that, I thank you very much for a patient hearing, and thank you for attending this conference and encouraging all of us with your support.
Thank you, Purvi, for evidence-based rebuttal against myths against sweeteners. Now I call upon both the speakers on the dais to have a group photo.
As we conclude our clinical diabetology session, I would like to invite our next chairpersons, Dr. Rashmikant Sangvi, Dr. Rajesh Yadav, and Dr. Renu Budhwani to take the stage for our next session, the final board.
Good afternoon, friends. Welcome to the session. I'm not sure everybody is hungry now, pre-lunch session. The interesting topic is whether it is better to have misal pav or to have idli sambar. And for that, to guide us, we have two eminent people going to be discussing and helping us. Dr. Shailaja Kade, who has done MD, FRCP, FSC, FSCP, MD Medicine. She is a professor in internal medicine and consultant diabetes unit at KEM Hospital, Pune. Since 1994, she has a research associate at KEM Hospital for 1992 to 2009. She is also director for SKDC Diabetes and Specialty Clinics, director for Orange Diabetes Medical Foundation and Research Center, Pune. I am a past chairman. With that, I shorten my introduction.
Thank you.
As per the Dr. Shaila's wish, and I hand over to Dr. Renu.
Our second speaker is, instead of Dr. Vijay Kumar, we have Dr. L. Srinivasa Murthy. Dr. Srinivasa Murthy is a senior consultant, physician, and diabetologist. Over to sir.
Thank you so much. And Mike, yes? Yeah, that's a good idea. I'm going to involve everyone. But they will vote for idli sambar and misal pav, right? So we are talking about general idea is fixed drug combinations in type 2 diabetes when we treat. So what do you think? Idli sambar is better or misal pav?
Idli sambar with chutney also, mind you. It's not only sambar.
So I think let's convert this whole thing into a discussion, and I encourage everyone here to participate in this discussion why we need FDCs, like fixed drug combinations, to treat type 2 diabetes. So some FDCs are blockbuster. It's not only idli sambar. There are so many things into that, and they became blockbusters in 70s. And we know that Polycap was first introduced in India with a very good trial, very good research base for the Polycap, and still we are using it. So we need these blockbusters FDC also for type 2 diabetes. Some fixed drug combinations sound different, but they work. So they work unexpectedly, or maybe they work for some time. So we don't know. So some FDCs are unexpectedly work better or some time. And this is the combination. This is the combination which has seen the blockbuster in Mumbai. You can see that what Manoj has done. A great thing, Manoj, congratulations for this. So combinations always take you to the good success. So let's...
But all combinations may not work also. Like marriages.
So there you need some third, I think, combination. Yeah. So the Srinivas, what is the philosophy for treating type 2 diabetes when the patient comes? Maybe newly diagnosed, maybe after 10 years. What do you think?
I think the first thing is to assess and risk stratify the patient, which we fail to do many a times. What is the stage, as Dr. Shailaja said, what stage of diabetes, how many years, the duration, what is their A1C, what are the comorbidities. We should take all these into picture and decide. And the problem with most of us is that we don't initiate the drugs as required, the clinical inertia. I think that is something which we should know. And how we do is as important as what we do. That is the basic, I think we should never forget in our practice, though most of us are busy practitioners with all referrals, but that is something we should do. Then from the glucocentric approach, we are all moving towards the patient-centric approach. That is what we need to, holistic management is what is required. So the basic pathophysiological defects, what we need to target at the earliest. Hit hard, hit early should be our motto in most of the diabetics whenever they walk in. And these are some evidences what we are trying to show, that the omnase octate, which has been now the basic pathophysiology, most of us agree, from 3 it has become 8, now it has come up to 12, 13, but
still these 8 defects have to be targeted in most of our patients. And these are the 8 defects which are there, and very clearly, I think this slide will justify most of our treatments in our routine clinical practice, that we need to aim at all the 8 possible as early as possible. The catch is that, we have clinical inertia of initiating these drugs very slowly, and average insulin initiation in India is about 7.2 years. And the average insulin, the way the patient's board is about A1C of 9%. And that is something which you should come out of that clinical inertia. And the onus is completely on us, whether you choose 1, 2, 3 drugs at what stage of the diabetes. And that's something we should look at. And these drugs are all available to us. It's only the inertia what we have to initiate to slow this progression into complications. That is what we do not do. And of course, the patient-centric approach, what we talked about. And the William Osler has clearly told years back that the good physician treats the disease and a great physician treats the patient who has the disease. So that patient-centric approach was there in his words way back, 100 years back, I would say. And Dr. Shailaja, the A1C, why you need to target, though we say it's a patient-centric approach, but why should we talk about the delay? And this is what I was talking about, the classical approach. And you see the patients where the A1C is above 7 and not receiving the intensification for just 1 year. And that will translate into an MI increased risk of 67%, stroke of 51%, heart failure of 64%, and the composite CV endpoints to the tune of 62%. Just by delaying our inertia for a year and not able to optimize or intensify the treatment. That is where we end up in trouble. So the bad glycemic legacy most of our patients have. And we know the recent ICMR in-depth study also that the pre-diabetics and diabetics, the increase in the burden of the disease in our country, that is something we should keep up. So this is again very clearly talking about the benefits of early versus late glycemic, and that is what we need to compensate and look at. Now, Dr. Shailaja, we need looking at these pathophysiological defects and the clinical inertia and the delay in intensification of treatment. Do you think the aggressive A1C lowering has got evidence vis-a-vis the hypoglycemia? Because most of us are worried about the hypo, weight gain, etc., about the side effect profile. What do you think? Why do we need FDCs early in the course of the disease?
Concept of treating is at day 1, go to 6.5 and gently, and then for that without hypoglycemia and weight gain. So that's the basis, initial first 1 or 2 kind of aims of the trial. And we have enough evidence why we need to, should not have hypoglycemia, especially in patients with severe disease, 10 years duration of diabetes. Here the severe hypoglycemia is bad. Any hypoglycemia is bad, even a small relative one, we need to avoid, but severe is definitely bad. So we need correct FDCs to avoid the risk of hypoglycemia. So when you talk of hypo, there are some non-modifiable risk factors which we can't do, more the duration of diabetes, genetic and other things, but modifiable risk factor includes glucose lowering medications. So which combinations will definitely reduce the risk of hypoglycemia? The whole early thing aggressive started with, we all know Defronzo, which was actually triple drug combination, where it was not for A1C at the end of 3 years. It was mainly what it showed that triple therapy, GLP-1 analog, metformin, and a pioglitazone actually improved insulin sensitivity and beta cell function. That was the whole basis of addict study which Defronzo did. So when we say aggressive A1C lowering, one thing is we are taking care of glucotoxicity. So you will see every drug improves beta cell preservation. So which is not in actuality, but we are taking care of glucotoxicity at the very, very beginning. So we need drugs which will lower the severe hyperglycemia. So we can't just treat with metformin. That is the basis, and that also will improve beta cell preservation. So when we talk about this, the combination, of course, we cannot go further unless we talk at least 2 points about Verify. Beautifully designed study, the early combination of vildagliptin and metformin right in the initial years of type 2 diabetes. See, you can see it was placed here compared to all other studies in just first 4 or 5 years of type 2 diabetes. And what it was, 2 important points, we all know it was better. So I'm not going to standard conclusion of Verify, but compared to, if you see the monotherapy failure is much higher in in patients who had young onset diabetes. So those who got diabetes early, they fail early on metformin monotherapy. And we have so many patients who get to come to us 35, 38, 42, 45. So we need to be very careful. And they also benefited with combination of DPP-4 and metformin. That is one very, very important sub-analysis lesson from the Verify. Then Indian patients on metformin monotherapy fail much more compared to their global counterpart. We also this with Professor Ramchandran's diabetes prevention program, that metformin was not working that great as American DPP in Indian patients. So definitely metformin monotherapy in young and Indian type 2 diabetic patients is not that great. So these young onset diabetes, definitely initial failure is less with combination. So you can see it was 35% failure for young onset diabetes on early combination, but late onset is only 30. And if you look at the metformin monotherapy, almost 60% failed who got diagnosed early diabetes compared to late onset who got diagnosed after the 40 years of age. So young people, Indian type 2, we need to think of combinations right from the day one. So that was the key findings, and more true, as I said, for young onset diabetes and Indian type 2 diabetes. The very another thing in triple combination was even these combinations with SUs were launched quite late because there was so much of criticism, and it was like whether it will work. Should I use a FDC with SU? Even pharmaceutical industry took some time to launch sulfonylurea. Sulfonylurea metformin, of course, we are using, but in the triple combination, it was launched a bit late. Now it is available. So what is, Srinivas, what do you think about this sulfonylurea myths?
I think SUs have been part of our practice from quite some time. It is about 5 decades now SUs in the market. That itself will talk about the SUs, because we say any business beyond 5 years is a successful one if it sustains. So it has been sustaining from 5 decades. In fact, you know the interesting story how SUs were discovered in World War II when the sulfur drugs were given as antibiotics. Soldiers used to have hypoglycemia. So the French physician, I've forgotten the name, apologies, he discovered it, and the German physician synthesized this for the first time. Talbutamide was the first one. And this all started with the talbutamide story with ischemic precondition. So this is what the UGDP study in 1970 was the first one which signaled that there is some cardiac problems with this sulfonylurea as a bracket. So that is how this disappeared. But now we have the so-called the third generation of the newer SUs. So that is where we are in today. And especially we know the market share of a glimepiride metformin combination. We should not name the brand, but it is about 53% market share in that segment of a double drug combination. That is what we have the faith in that, because we know, as we saw that in India, the baseline or the controlled group of diabetics with A1C less than 7 is the tune of 70 plus. 70% of them are not controlled. So there is no question of that hypoglycemia, what we fear in most of our patients. So because I'm sure all of you get the referral patients, what we get, and this is what is the data now to show about the rural and the urban disparity in our country. There is a big gap, of course, and this is what I was talking about. The 53% market is covered by the SUs. And mind you, what Dr. Shailaja was showing about all the RCTs, the leader, the EMPA-REG, in the leader, 51% of the patients were on SUs. In EMPA-REG, if I remember correctly, it was 43%. In Examine, we were part of Examine also, it was 44% of them, background medications were sulfonylureas. So they have time tested when it comes to even the RCTs, which are the game-changing RCTs, which EMPA-REG or the DCCT, all them add this as a background medication. 50% in general of them were on SUs. Now this is again to show the evidence that the second line agents for glycemic control, the newer agents are better, and use of sulfonylurea, which again the guideline recommended, most of the guidelines talk about SUs as a second line drugs, and it is still there. Now in spite of all this, we have the SGLT2s, the GLP-1s, the 2G, 3Gs which are coming up. In spite of all that, SU is still there in all the guidelines as a second line, and when you look at, you want to control the sugars, and this has to be there. And the regimen with SUs resulted in the longest time to insulin dependency. That's something very heartening to see that. And this is the HbA1c reduction by different agents when you add on to the metformin. You can see the SUs in the tune of 1 to 2%. And I'm sure all of you agree, whenever a walk-in patient comes with a very high A1C, the first agent we will think of, apart from metformin, will be ASU, and most of it is the
modern SUs, what we call. Now, this is a paper to show the effectiveness and safety of glimepiride and DPP-4 with metformin in second-line pharmacotherapy with respect to the SAEs, that is, which includes severe hypoglycemia as well, 9% versus 11%, and that is a small absolute, is not a statistically significant number. So this is again very important for us to know. And of course, the weight gain part, which we always talk about. And this is the evidence to show that the addition of SU to metformin does not give rise to the change of weight, what we talk about. So strict glycemic control can be maintained with the SU and metformin in real life setting without relevant changes in the weight. So we almost call it as a weight neutral drug. We do not talk about that weight gain part. And this is again the advanced trial, which was with the gliclazide, and that was one of the best trials so far as SUs are concerned. And you can see the weight change in this arm with the gliclazide was 0%. And of course, the cardiovascular mortality, the blame game of this, as I said, was with the UGDP trial initially in the 1970s, but later on in 99 and 2000, there are studies done, mechanistic studies done with the angiogram in place, and people were given glimepiride and glibenclamide and showed that ischemic preconditioning does not happen with glimepiride. There are enough evidences, there are meta-analysis to show that glimepiride and gliclazide are the two molecules which are much safer as far as the ischemic preconditioning is concerned. So the cardiovascular mortality, the myth definitely does not exist, and it is very, very less with the glimepiride because of its mechanism of action. With the 64 delta on the receptor activity compared to the other, because the glimepiride has got a high affinity for dissociation, low affinity for the receptor. That's why even the recovery of the hypoglycemias are better with this glimepiride molecule. And this is, of course, ADA 2018, that the modern sulfonylureas, they've clearly told about the safety of cardiovascular. They've clearly told the efficacy is high, CV neutral, low cost, and renally they're neutral. This is what is the recommendation. And of course, we know the guidelines are based on the meta-analysis and the RCTs, and the idea of clinical practice recommendation for diabetes, 2017, they've clearly told modern SUs are CV safe, and that is a statement which has come up after the IDF in 2017. And of course, the EQPDS again showed us that there is no literally that solid evidence of beta cell exhaustion, and diabetes itself can result in the decline in beta cell function over a period of time as aging advances. And the beta cell exhaustion, they literally question, is there any difference within the SUs? That is something to be answered. And of course, we talk about the combination, earlier the better, hit hard, hit early should be our concept whenever we see the patients with this. Now, of course, the fixed drug have got advantages, mostly little disadvantages of individual titration may not happen within the drug, but there is always a synergistic complementary action whenever we try to combine. And SGLT2 DPP4 with metformin, SGLT2 glimepiride with metformin, these are the FTCs which we look up in our routine clinical practice to have the lesser pill burden, and of course, the recommendations are the backup for that. Now, Dr. Shailaja, the heart failure component of glimepiride, do you think it is something to be worried?
Yeah, I think as we were talking about sulfonylurea and cardiovascular safety, this was the paper actually published, it was presented few years back in ESC, where a group of investigators who believe in the arachidonic acid and myocardial metabolism, they used glimepiride in patients with chronic heart failure. It was a retrospective study, and what the prospective cohort study, actually not retrospective, and then they found out that glimepiride use, the survival was better. There was about 509 odd patients of type 2 diabetes and chronic heart failure, glimepiride users versus non-glimepiride users. There was a propensity score matched, and Cox regression analysis was used to match the two groups. And survival was better in patients using glimepiride of chronic heart failure and type 2 diabetes in both hospitalization for heart failure as well as cardiovascular mortality. They also compared the different doses of glimepiride, and the higher the dose, the survival was better, hospitalizations were less. That's what the authors actually said. This is the group actually working for the arachidonic acid metabolism, and they say the glimepiride has the unique effect which it preserved EET, and that's why the survival was better. I'm not saying recommending that we start using glimepiride in heart failure cases of type 2 diabetes. We have enough good drugs, but that big kind of a cloud of question mark of glimepiride or SUs about high severe risk patient, at least it gives us some kind of a comfort that if I'm using a 0.5 mg of glimepiride in a fixed drug combination, I'm not creating a big harm to my patients. So, and Carolina, what it showed is actually the safety of glimepiride. In spite of that first 4 initial titration phase of hypoglycemia, it did not convert into the high cardiovascular risk. And even the hypoglycemia in a clinical trial setting, because you need to increase the drug as a rule, whatever is the protocol. In clinical practice, we don't do that. We have very small doses of 0.5 mg, which we can titrate in a much better way, not like in a fixed protocol, so that we can avoid those severe hypoglycemias. But even Carolina gave us a lot of confidence of using glimepiride. So that...
And 44% of them were on glimepiride arm versus
Yes, so
the
it was-
Lina in this.
So
That is
enough
something
kind
again.
of a things that these new SUs like glimepiride or glycoside, we can use in good doses without creating hypoglycemia in a fixed drug combination. And we have so many combinations available, 0.5, 80 extended release glycoside and so on. So definitely these FDCs work much better. Just one word I think about this fixed dose combination of basal insulin and GLP-1. What do you think? We have one, the second is coming.
Yeah, I think it's great. I was part of the trial as well. And these are some things which are very promising. But the problem with most of us is the clinical inertia to initiate these at the right time. That is what I think we have enough evidences now to talk about all this. And but the problem is the inertia with the physicians, with the available. Of course, we're not saying no, whoever walks in, you have to start with the triple drug FDC. But the point is the right time of initiation of these drugs for the right patients. You know, when the SGLT2 or a DPP4 or a metformin, one of the great combinations where the pill burden comes down, and the adherence is the biggest problem in our country because most of the patients affordability part. And now, thanks to our pharma friends, they brought down the prices of these and made it very affordable to our patients, and that's something which is there. And Shailaja, can you just enlighten about the adherence advantages with the FDCs?
Thanks. I think there are many points, but we just speak about adherence for just 1 minute.
Yeah.
I think whatever we do for type 2 diabetes management, all these pillars are based on adherence. So unless the adherence is there, whatever you do, SGLT2 inhibitors, prevention, 1 or 2, 3, 4, 5, your aims will not be correct unless patient takes it. Again and again, many kind of meta-analysis have showed the number of drugs, polypharmacy, age of the patient, and cost. Actually, they are a significant relation with the non-adherence, which is so important to go to the targets which we plan. So this is kind of a lot of papers which will talk about cost, monthly income, SMBG. It actually improves adherence, number of medications. So again, here comes the role of fixed drug combinations, which will improve adherence. Another study, again, it's a kind of a meta-analysis, has shown that adherence may be different with different class of drugs. You will be surprised, you can see sulfonylurea is almost 61%, as well as SGLT2 inhibitors, even TZDs. Metformin is actually less because of the side effects which we know. So this is also very good reading that what happens to each drug. This is very good kind of, this meta-analysis says that no difference between men and women. Older patients are more adherent and poor adherence in younger patient is alarming, as we were talking about Indian type 2 diabetic patients. Monotherapy versus polypharmacy. So again, FDC has a big role in young Indian patients who do not want to with a big list. So I think adherence is important. Protecting organs, I think we have heard this again and again. So we just go through that. We need to protect. We just heard prevention of MASH, but you can see about kidney disease, the GFR as well as albuminuria, both we need to target. And at all stages of this KDIGO, we know that SGLT2 inhibitors work wonderfully as well as GLP-1 analogs. So if my FDC has these kind of drugs, I'm very sure to protect kidneys right from non-albuminuric stage to maybe even overt proteinuria, where I can bring it back to non-albuminuria. So this is again a good thing that I can have SGLT2 inhibitors in fixed drug combinations. So I won't go into the variability. So this was actually a DEVOTE kind of, I was a part of DEVOTE, and this was fasting glucose variability. More the variability, poor was the outcome, and we know main outcome was severe hypoglycemia, which we can again avoid by having a good combinations good kind of a FDC like metformin, SGLT2 inhibitors, maybe alpha glucosidase inhibitor to avoid those peaks and the valleys in patients kind of a glucose profile. And yes, one size doesn't fit all. So every FDC may not be useful for each and every patient. So your comment, Srinivas?
Yeah, I think that already I told about that is the number of combinations available may be confusing many a times. What is the trade name and the components in that? That is the flip side of the story. But end of the day, we know that now we need to be a patient-centric approach, not the glucose-centric approach. Start the combinations early so that the adherence is always there and the burden of micro and macrovascular complications with the right combinations, if you reduce, I think that is what we require. And of course, this is a classical qualities of any combination where you need to have the protective mechanisms as far as the microvascular. There should not be minimal hypoglycemia. There should be minimum weight gain or weight neutral or in fact weight loss now with all the SGLT2s and the GLP-1s. And that is what you need to look at. Hit hard, hit early is our motto.
Yeah, so I think lastly, I want to say that idli sambar is a good kind of FDC. Some like it, some may like misal pav better. So it's one size doesn't fit all. And you can combine idli, you can combine pav and sambar. So maybe sometimes some people may like it that also. But idli sambar is not sufficient. We need chutneys, we need vadas, and we need coffee. Right?
That's a
Am I
perfect
right? The
South
Bangalore
Indian,
way?
Bangalore way and South Indian way. And thanks, Manoj, and you're paying the bill for that idli sambar, which I'm going to have now.
And even with misal pav, we need this kind of a special buttermilk, which we get in Pune. If only misal pav is not sufficient, we need a third drug, we need a fourth drug, and tea is always welcome.
Great.
So it can be a metformin in every FDC.
Yes.
Thank you so much.
Thank you. Thank you. So I thought, let me thank everybody for staying back for the session and the valedictory. But before we really conclude this, and I've said this enough times here, last year when I was speaking at EAST, and we have international faculty with us here. Does the international physician community feel jealous of us Indian physicians having the opportunity to use these triple fixed drug combinations at a very affordable rate? I would invite comments from anybody of you who wants to say, are you waiting for these kind of FDCs to be available in your country?
I think that's the answer. Dr. Peter is welcoming that.
Thank you.
Thank you.
Thank you.
Thank you so much.
Let's come to the center for a group picture of this session.
Thank you, sir. It's definitely a good eye-opener for us. Only thing is, recently, some irrational combinations have been banned by the government, but rational combinations are very much appreciated. Thank you, sir.
again, thank you all for staying back till the end. Means a lot to us that all of you are here. Purvi? So let's begin in this valedictory function with announcing the names of the winners for the e-posters and the oral papers, right? So we received
So we were extremely pleased to receive the number of posters and the abstracts that we received for evaluation, and we had a committee set up for that. And I thank the committee chairs also for the same, for reviewing them. And the oral papers, And before we begin with this, I think there are two individuals who have to be on stage for this. Professor Dr. Yako, please join us on stage. And Professor Dr. Peter Schwartz, please come up on stage. Is Professor Dr. Ramchandran here? Dr. Amit Gupta? So of all the entries that we received, and among the oral papers presented, the first prize goes to Dr. Bruce Duncan. And the second prize goes to, unfortunately, he is not here. He had to leave this morning, Dr. Bharat Sabu. Co-authors from that from the presentation can also probably come here and collect it. There's a cash prize for this in Indian rupees. The first prize winner gets 15,000 rupees and the second prize winner is 10,000 rupees. Congratulations to all. Dr. Shibani is a co-author on the oral presentation that Dr. Bharat Sabu led. And trust me, I think others should not get disheartened. It was a tough tie, as we understand from the judges. Congratulations. Now for the e-posters. The first prize again goes to none other than Dr. Bruce Duncan. That's a smash hit. And the second prize, there is a tie between Dr. Pranjali Shah and Dr. Ariana Trehan. Congratulations. It's Dr. Araina Trehan and Pranjali Shah. Second prize, e-poster.
everyone who sent the abstracts, thank you. Well, the ones who have won it through a individual judging process do deserve it. But many of you whose abstracts were either not accepted for orals or posters, or within that didn't make it, you know that you've lost to some tough competition from across the world. We want to take a minute to thank the judges who helped us with the judging process. Well, initially in the entire screening, and we had kept this confidential till now, but I think we can thank individuals who helped us in the screening of abstracts. Dr. Pablo Ashner, thank you again, Dr. Pablo, for doing the screening. Dr. Rakesh Parekh, and Dr. Purvi Chawla. So it was a process that all three of them individually did the screening of the abstracts, and then based on what everyone had scored, they were selected for orals and then for the posters. The orals were judged again by two set of clinicians and faculty from here. On day one, the oral papers were judged by Dr. N.K. Singh from Dhanbad and Dr. Navneet Wadhwa. Both of them, I don't know if Navneet's come back, but thank you again, judges, for doing that. On day two, we had Dr. Pablo Ashner and Dr. J.J. Mukherjee, who were the judges for the oral paper. So judges, thank you so much for doing this for us. The e-poster session again was very interesting, time consuming for the judges as well and the presenters, but it was a separate hall that we had kept, which was all packed. And I want to thank the judges who took their time out. I'm sure it was a difficult process for them, but I want to thank Dr. Arvind Gupta from Jaipur, who's probably traveled back, and Dr. Kiran Shah from DRS from Mumbai for doing that. Kiran and Dr. Gupta, thank you. Thank you. Okay, so we now want to, it's an overwhelming feeling for us at the end of this 3 days. Something that was conceived and spoken about for a year now finally happened. At DRS, we are again extremely thankful to the WCPD board for giving us a chance to collaborate, and want to once again take the opportunity to thank Professor Jaco Tumilito for making this combination happen, and the entire WCPD board, Dr. Rafa Gabriel, Dr. Noel, Dr. Pablo Ashner, Dr. Sudhir Sen, and many of the international faculty. Yes, may we request the WCPD board members who are here to please come up and join us on stage. Dr. Pablo, Dr. Rafa, Noel, please join us on stage. The entire international faculty who's traveled from across the world and being here. So again, let me invite Dr. Bruce, Dr. Maria Schmidt, Dr. Paula. I'm trying to see who else is there, but I'm requesting them. Dr. Nebovich, the entire international faculty who's still here, stayed back with us. Dr. Timolaka, Dr. Lee, Dr. Sylvia, yeah. Dr. Ilan, Dr. Shehnaz. Sorry, you guys have mixed in so well with our crowd that I couldn't differentiate and see you all, right? But I'm glad that you all are here, right? So big round of applause.
Professor Ramchandran, sir, is he here?
So I would like to thank the local organizers here from India for this great possibility to join the meeting with the World Congress on Prevention of Diabetes and its complications. International meeting with the local Indian colleagues has been a really good experience, and I think we should give a big hand to the local organizing committee. And of course, all the participants. When we are talking about the prevention, then I have to admit that our survival rate has not been very good. This is only survivors now here, and in the beginning there were many, many more. So I don't know what happened. They dropped dead or dropped out or were hospitalized or whatever. I don't know, but thank you for you survivors who are now here from the faculty of the World Congress on Prevention of Diabetes and its complications. So we are hoping to work in the future and hoping to have a next Congress in about 2 years' time again somewhere in the world, because we go from one place to another with our international Congress. And thank you very much, and enjoy your travel back home.
Thank you, Dr. Yako, for those very encouraging words. And thank you for bringing the world's experts to this platform of DRS. We were more than happy to host this meeting. And I think there are 3 individuals who need special blame for this. And that's Dr. Banshi Sabu, sir, Professor Dr. Ramchandran, sir, and Dr. Amit Gupta. So a big round of applause for them that they made it happen, and it's been over months that things have come together. May I now invite our very popular and very present, the IDF President, Dr. Peter Schwartz.
Very popular, very present. I just was surprised. It was totally cool to be here at this meeting. If we look at this room, if you look into the walkway outside, at all the corners, the discussion that took place, this is really the teaching. This is the spirit and the passion to become a warrior against diabetes. And I'm very confident that the people who are here in the room, the people who attended this Congress, they will spread the message and at the end will become the future leader in diabetes care, but even more important, the future leader in diabetes prevention. So let this meeting become a good soil in a fertile ground where a big tree is growing out of it, and this tree carries the name, maybe warrior against diabetes or prevention of diabetes. And I will make a promise. This topic, prevention of diabetes, will become a leading objective, a leading goal and mission for the International Diabetes Federation on all different levels, in all different directions. So if we meet again, I hope we can document progress. Thank you very much to Pobi. Thank you very much to Manoj. It was very cool to organize this meeting here in Mumbai.
Thank you. Well, you know, what you see here are 2 people who are taking credit for all the work done by a lot of people behind. So it gives me great pleasure to invite the entire DRS organizing committee, who's being a strength of support, suggestions on topics, on the way we do things, deliberations. We have separate scientific committee, our national advisors. We have then multiple different committees, including the newsletter committee. So a lot of suggestions come from within social media handlers. So a lot of suggestions and help comes from people who've been doing the work. So Purvi and me are the front faces taking the credit, but we want to with all our hearts, acknowledge the work done by the entire team and request with folded hands,
The
everybody
performance
from
committee.
DRS Organizing Committee to please join us on stage. Everyone from DRS Organizing Committee, it will be difficult for me to take the names. We have a huge support from within our community and hence requesting everyone from DRS Organizing Committee to come up on stage.
And the National Scientific Committee as well.
The organizing
All those who are
committee,
here, please do join us.
the National Scientific Committee, national advisors and patrons, if any here, please join us.
And another group of individuals who have been our constant, sort of sounding barrier, our shoulder to lean on, cry on, everything is none other than the Leena Diabetes Care, Diabetes and Beyond, and Mumbai Diabetes Care Foundation team. May I invite all of you on stage, Amisha included.
Thank you guys. You are our strength and support and continue to give us suggestions to improvise. Please give us feedback and this goes out to all the faculty. All our delegates as well. We have the website for Mumbai Diabetes Care Foundation. It's there. Give us the feedback, any kind of feedback for us to improve what you're not happy about, and we'll change things. At this time, let's also acknowledge that meeting. We want to thank all our collaborators who collaborated with us for this meeting. We want to thank DTech, Diabetes India, D-Genius, and the Indian Medical Association.
Breakthrough Type 1.
Breakthrough Type 1, yes. And the Indian Medical Association, Mumbai West Suburban Branch, and the Ghatkopar Mulund branch is called as NBE. So thank you again, the collaborators, all of you, for giving us that support. We do realize that meetings like these would be difficult without the support from the industry. We did show in our inaugural video that this year we've been blessed with support from the industry, more than 45 industry partners who came ahead to support this. So again, a round of applause for all the industry. We're going to call out their names as put up in our brochures here, and I would request a representative from each of the company if they can come up, and I would request again Dr. Peter and Dr. Yako to join us. Sorry for making you do this exercise on an empty stomach, but Peter is used to fasting because Right. Thank you. So again, would request a representative from these companies. Any of you who's here, please join us. US Vitamins. Anybody from USV? Yes,
Please.
Manoj Badoni, thank you. Right? And I may not remember everyone's name, so apologize for the same. Cipla India Private Limited. Somebody from Cipla, please. Microlabs, a big support given to us by Microlabs. Novo Nordisk, Sanofi, Lilly, Abbott Diabetes Care, Sun Pharmaceuticals, Lupin Pharmaceuticals, Areen Pharma,
Medtronic India, Eris, Glenmark, Torrent Pharma, Mankind, AstraZeneca, Boehringer Ingelheim, Metalis Life Sciences, Abbott Healthcare, IPCA, GSK, Nirvana Healthcare, Zydus, Abbott Nutrition, Natco, Alembic, Aristo, Bayer, Roche, Macleoids, Newcare, Servier, Dr. Reddy's, Intas, Zuventus, Alchem, Zydus Wellness, Merck, Cody's, Sinocare ICANN, InBody. Have I missed out anyone? JB Chemicals, Procter and Gamble, Thank you. A very, very big thank you to one and all. If there's anyone else, please come here on the stage from the industry. We would like to acknowledge you and thank you for your support. The audience is unparalleled.
Thank you, industry. And in particular, we wanted to get this picture. Most of the checks are remaining to come, so we wanted to get the proof. Thank you. Thank you. Your support means a lot to us and allows us to do our bit in the field of spreading education and making everyone here warriors in our fight against diabetes. So thank you, our pharma partners. Okay. Just a few more minutes for us to thank our remaining team. We wanted to invite our observer from the Maharashtra Medical Council, and of course, a very, very senior member, trustee of IMA and many other associations across Mumbai, one of the most senior and respected family physicians in the city of Mumbai, Dr. Bakulesh Mehta, as an MMC observer and from IMA Mumbai West, who wanted to say a few words.
Dr. Shobha Ahuja, a very senior practitioner, and IMA Mumbai West President, immediate past President. Do we have the current President, Dr. Ketan Mehta? Thank you so much.
Good afternoon to everybody. 2.5 days were very, very hectic, but very enjoyable. I have been attending many conferences last few years, but it was the most unique conference which I attended. Usually, I don't remain for 3 days, but this time some attraction. It was a unique conference, well attended, well planned, unique type of menu. Both of them we enjoyed, and I both the all DRS team require big compliments, and particularly to Manoj and Purvi. And I wish them more and more achievement in their life. Thank you.
Well, we want to thank our two partners, IJCP, which has been our event partner and our educational partner over the last few years since we started. Mr. Nilesh Agarwal and team, they're also responsible for getting out the newsletters that we put on the groups, and you will receive the highlights of day 3 also tomorrow as the soft copy. So Nilesh and team, thank you. They were here. Nilesh was here till yesterday, but had to then move to Delhi. And then, of course, our new event partners since last year who've taken up the responsibility. So if your stay, food, travel logistics, AV, all of this has been good or bad, we still would blame it or give accolades to the team RX.
I think it's all accolades all the way. They are a very calm team as compared to any other events team, and absolutely on the forefront of managing everything. Very little input required. It's all seamless with them. Of course, minor glitches are not under anyone's control. But let's give it a thumping applause to the RX team led by Dr. Hardik Chandrana and key people from RX. Everyone is key, but I just am going to say a few names. Neelam Chandrana, Uma, Rahul, and everyone, the entire RX team, please come on stage.
Rahul, Ankit, I want the entire team from RX to be here. I think Stuti did her job and now she's taking a nap. So, and then some of these guys definitely need a nap and sleep the way they have worked for the last 3 days. So thank you, team RX. Right? Again, the work, what you see is what's happened in the last 3 days, the planning, the whole aspect of going back and forth, allowing us to hold meetings, venue, menu, designings, creatives, logistics, travel, a lot of that is done. So Puri and me can sit back and enjoy meeting people and networking and doing the crazy things that we did over the last 2-3 days is thanks to Team RX.
Thank you, Manoj sir and Purvi ma'am for giving us this opportunity. Since last 2 years, yes, last year and this year we have done this event, and this time, of course, joining with WCPD and when you do an event with Purvi ma'am and Manoj sir, you know, there are a lot of learning points. They'll keep you on toes, even if it is at night 12:30 or morning 6:30, they'll message you, kya hua bhai iska, what happened, why this is not done. So we are also learning a lot of things since last 2 years, working with Purvi ma'am and Manoj sir, and of course the other members of local organizing committee. So thank you everyone for giving us this opportunity.
Thank you. In the picture, Rahul left because that's what he does. He receives calls throughout the day and night to attend to all requests for logistics. So big round of applause to not only entire team RX, but special mention to Rahul, who's probably had sleepless nights for the last few days handling the calls and the logistics. Thank you. Well, let us now take the opportunity to thank this beautiful venue, which is Western, and Hardik, can we have Brenda or somebody from the team, the hotel? They're all busy with the food. So, well, I think they've done a fabulous job. This is a fabulous venue. We were used to hosting our earlier conferences at the earlier organization years back before COVID, but we've come back around whole circle, and as DRS and WCPD had the opportunity to host it at this beautiful location. Not only is the location beautiful, they have a wonderful convention facility, and they are truly connoisseurs to the sense of serving food, being polite, and giving into all our requests, including crazy ones going beyond past midnight. So big round of applause to the entire staff of Western from the Marriott Group for being so cordial and taking care of us. Finally, let us conclude by thanking what makes a conference like this the success if it is. And that's the strength of the doctors attending these meetings. You and me would mean nothing if we were speaking to empty halls. So the delegates that have attended this meeting, we've been blessed to have delegates from at least 8 different states of India, traveling from northeast of India to the south of India and some of the northern states. Of course, the local Western delegates coming in from Maharashtra, Gujarat, and MP. We welcome all of you. Thank you for being a strong support, and our local delegates from the city of Mumbai, Thane, Navi Mumbai. Thank you so much for being here, and I can see some of the delegates who have stayed back till late. Thank you. It is you for who we continue to strive to do better and make these meetings. Of course, let me acknowledge the contribution of the entire faculty for this conference. We acknowledge the international faculty, but our strength comes from our colleagues and KOLs from across India. So let me reach out and thank the entire national faculty, and some of them have waited back. I can see Amit, Rakesh, Rajesh, Alok, and many of you beyond our DRS team from India who stayed back as our local faculty. So the entire faculty, thank you for accepting our invitation and contributing significantly to this meeting. We had kept the entire session as virtually live, and we are getting the numbers as we speak about how many people have attended this in different halls. But pleased to say that besides the physical attendance, I think we've had about 1,200 people join in into different halls on a virtual platform.
And this would not be complete without thanking our performers, Dr. Yuti Sheth and Ms. Dhwani at the inauguration. And the entire Maratha theme, took over so beautifully by Mr. Bhavik Lad. And I have to say it was under the leadership of Dr. Shubhashri Patil. I acknowledge all the dancers and all the performers for, conceiving and actually putting up such a fantastic show in such a short time. Thank you very much for this entire performance. Thank you, Ashna.
Thank you. With this, if you missed out on any of our partners, and thank you, apologize us for the same, because now a bit hypoglycemic. Inviting all of you to join us for lunch, and reminding you that the dates for the next year's DRS 2025 is 23rd and 24th August 2025. So please mark your dates, and we'll see you back in Mumbai. Right? Thank you. Have a wonderful lunch, and have a safe and good travel back home to all of you who leave today or tomorrow. See you real soon. Right? Meet you at lunch. Thank you. Purvi is pointing to me and kind of trying to say that you didn't thank me. So